Hello again, and welcome to Class 10, the last in our Calcium Masterclass series, brought to you by Shockwave and Optima Education. Our final show is entitled The Deep Dive on Calcium, Bringing It All Together. As with previous classes, feel free to message us directly in the chat box at the side of this video player, and we'll do our best to answer your questions.
Our live case today is from Bristol, operated by Julian Strange and Tom Johnson. And it will be moderated by Emanuele Barbato from Italy and Ajay Kirtane from New York. Emanuele will also be talking to us about the European perspective of calcium modification, and Ajay will be telling us how effective calcium modification may change revascularization indications.
And we'll be finishing the series with a live Q&A with special guests who have asked important questions over the course of the series that we want to respond to directly.
But now it's time for a European perspective on calcium modification, and we're joined by Professor Emanuele Barbato. Hi, Emanuele.
Thank you very much, Jonathan. Hi, James. Thank you very much also for having me at this event. It is for me a privilege to share with you the European perspective on calcium modification in 2021. This is my agenda. I'll start off by sharing with you what is the current situation in terms of plaque modification in Europe. And there's nothing better than just sharing the experience from the community. We have collected good data from in the period of 2016-2018, and I refer to the Euro4C registry that specifically focused on rotational atherectomy. 1,000 patients in 19 European countries, evaluating the adoption technique for this device and the clinical outcomes. These are the patient characteristics. As you can see, these are high-risk patients, 43% diabetic patients, peripheral vascular disease, very common, multivessel disease, renal failure, and so forth. And this is the first interesting finding to reflect upon, that is the contemporary adoption of rotational atherectomy in this country. Radial approach was very common. There is still some heterogeneity, but overall, this procedure is done mostly through radial approach. Sheath caliber size went down. We can do most of this with 6 French guiding catheters. Maximum bar diameter, 1.25, 1.5 millimeter. Very short rotational atherectomy duration, less than 60 minutes. So it really seems the colleagues have learned the lesson of early days and tried to minimize the complication, the possible complication associated with rotational atherectomy. And as a matter of fact, in-hospital complications rate was quite low in the single-digit range, as you can see this slide. And this is the one-year clinical outcome where we have reasonable all-cause mortality rate and MACE rate up to 12 months. With the availability of novel devices and technique, the community adapted their practice, and in 2018-2020, we accumulated nice data on the adoption of intravascular lithotripsy. This is the UK-Italy registries, 6 centers in total, sharing their experience in procedural success in IVL treatment of calcified lesions, and also detecting MACE rate in this patient. And again, you will recognize more or less the same risk profile of the patients included in the European IVL registry as compared to the rotational atherectomy registry, which nicely also compares to the DisruptCAT 2 and 3. You can immediately see that despite the early days adoption in these 2 registries, nowadays we are adopting IVL in more challenging patient setting and angiographic setting. Here you see adoption in in-stent stenosis, left main stem, that was one of the exclusion criteria of DisruptCAT 2 and 3. IVL in saphenous vein graft, multivessel disease patient, CTO, and undilatable lesions. Interestingly, up to 17% of patients did combined use of rotational atherectomy and intravascular lithotripsy. And here we come again to the clinical endpoints, quite reassuring. Despite the challenging patient population, the treatment of calcified lesions with IVL resulted in single-digit event rates up to the latest follow-up available in this study. That was nearly 1 year. And these endpoints nicely compare with somewhat less challenging patient population that was included in the early experience with DisruptCAT 2 and 3. nowadays, we have different treatment options at our disposal on our shelf. There is a new kid on the block in Europe, namely Orbital atherectomy. So there is really no excuse anymore to optimize the management strategy of these patients. We cannot claim that we do not have the right tools. So intravascular imaging confirms that our technique, our devices can effectively modify the calcium. We can do that with rotational terrectomy. We can do that effectively with intravascular lithotripsy. Look at cross-section C, this scary circumferential calcification there, how it is disrupted in cross-section D by several runs of intravascular lithotripsy, enabling to achieve a nice stent expansion and stent wall apposition. This brings us to the last point on the agenda, the need for tailored approach. Why do I want to mention this in my talk? Because despite we have at our disposal all these devices and techniques, the penetration of these techniques are still lagging behind. This is coming from the consensus document in 2015, very low penetration of rotational atherectomy and very heterogeneous among the different European countries that were queried in 2020. The optimal adoption of these techniques starts from an early identification of the severity of calcium. Although it's not that always easy, there are some early predictors that might in a way anticipate the need for plaque modification. Already before entering the cath labs, we have clinical predictors. CCTA itself, that is increasingly being adopted, can provide us some indication. Coronary angiography, unfortunately, is limited unless you really have severe calcification. That is a call to use intravascular imaging. And even you haven't done all this, once you are in the middle of PCI, you still have a bonus. In case you see that your balloon doesn't cross or doesn't dilate properly the lesion, then stop, think it over, and move to plaque modification technique. Intravascular imaging is helping us a lot. There are some iteration of the devices. This is just the latest version of the OCT software, the Ultron 2, that allows not only the identification of calcium, it is really done for dummies in the sense that it tells you how much calcium is there in terms of arc and how much thick is this calcified plaque. So tomorrow, that will also trigger a message that will tell us this is now the moment for you to adopt a plaque modification tool. And then you see the same image magnified. The importance of the learning curve in the device adoption, that is key. The more we learn the place of each of these devices, the better we start adopting them. And this cannot this cannot escape an adequate training and education in device selection, also by the means of intravascular imaging, as we have seen with the software related to the OCT. This is more of a personal thought. We should try to escape the tool or toy for all race. The simple availability of a novel device on the market, that doesn't mean that everyone should immediately jump on that. So in other words, I'm personally against the use of more flashy device in the hands of inexperienced colleagues. I would rather see these devices to be adopted by experienced colleagues first, and for all the others, I would encourage to not escape the learning curve that everyone has gone through before starting treating a challenging lesion setting. We should not forget this. No matter how beautiful the device is, the challenge of the lesion setting remains. This is a very last two slides from a recent talk of Margaret McIntyre at the latest EuroPCR, telling us what is the prevalence of combination therapies, which is nice. Again, if we would have unlimited budget resources, no matter what, you can play with all these devices and tools, but not forget that the other side of the medal is that the more devices we use together, the higher will be the impact on procedural costs, which is something that we can perhaps limit if we learn how to correctly adopt them depending on the selected lesions. So these are my conclusions. In 2021, optimal treatment of calcified lesions in Europe is facilitated by several tools and techniques available. Yet their over-enthusiastic adoption should not escape a rigorous learning curve, considering the not forgiving anatomic and clinical setting. And adequate training and education is key, in my opinion, to provide guidance for optimal device lesion matching in a cost-effective fashion. Thank you very much. Back to you, James and Jonathan, for the discussion.
Thanks, Emanuele. That's great. Listen, let me start with your last point. Effective education and training is necessary to implement these tools and assimilate them within our existing understanding. So what would you say are the three most important educational points that we should be focusing on that we're not at the moment?
So first of all, I think we should start spreading the culture of carefully reading the coronary angiogram. Everything starts from there. We think we can master this diagnostic tool, but that's not actually the case. Everything starts from there. Early identification of the severity of calcified lesion. So even before thinking to learn how to use all these fantastic tools, we need to understand when to use them. So the first point would be indication to plaque modification. That is top in my list. Number two would be optimal procedural setting. You know, effective treatment of calcified lesion really starts from the right selection of the vascular access, from the right selection of the guiding catheter, of the guide wire, and so forth. Many uncrossable lesions are not really uncrossable. It's simply because we have suboptimal support. So that is another important point that we need to keep preaching. And of course, the last but not least important point is to master all these tools and techniques. And we need to do it rigorously, step by step, without escaping. I have seen early days of IVL adoption in the hands of colleagues who have never done a single rotational atherectomy case. That doesn't mean you need it, okay? But the fact of having already gone through the training in challenging lesion setting would also teach you when was the right moment to use a device and when was not the right moment, because you can have the most fantastic tool in your hands, but you can spoil it all if you do not adopt it properly.
I think that's absolutely right, Emanuele, that actually we quite often like to blame our equipment when perhaps the responsibility lies closer to home. But I would just challenge you on that rotational atherectomy. You know, we've had this technology around for 20 plus years and its adoption is poor. And that's not the same thing as its efficacy. I don't think any of us who do complex PCI would argue against, in the right scenario, rotational atherectomy remains a real fundamental pivot point in the managing of calcium education and calcium management. But at the same time, we haven't managed to increase its penetrance in the last 25 years. So it may well be that IVL might be able to reach those operators that you refer to, the ones who just didn't want to adopt, for whatever reason, rotational atherectomy, but feel more comfortable with a balloon-based technology. What are your thoughts on that?
I think this is very possible, James. We have to admit that these techniques, and I refer to the rotational atherectomy techniques, are complex, are not easy to use, not really for everyone. And they need to be done in a controlled fashion. And I agree with you that IVL might overcome this barrier in adoption. But again, as long as the users of IVL bear clear in mind what is an uncrossable lesion. You see, what I happen to see, especially in the early days, is to keep insisting on balloon dilatation just in order to advance the shockwave balloon. That is something I don't want to see. If a lesion is uncrossable, no matter you keep insisting, that's not the right setting. But I agree with you that in most of the cases, shockwave might increase adoption because of the simplicity in the technique, for sure.
Actually, there is a mechanistic rationale from an IVL side as well, Manuel, not to force it into critically narrowed lesions. It doesn't work as well. And of course, you can also rupture the balloon. And actually, as you correctly and eloquently say, it's about understanding equipment. It's not about just taking something off the shelf and applying it to your mental mind map. There is actually, or there should be, systematic learning behind all this equipment. Jonathan?
Well, I think that the point about whether a lesion is uncrossable I accept that the points you've made and where rotational atherectomy clearly has a role. But we shouldn't forget that within the Disrupt series of trials that the lesions included were all crossed. They were crossed facilitated by a semi-compliant balloon, a 1.5 or a 2 millimeter balloon, and it was a significant proportion of cases that the IVL catheter was facilitated in crossing with adequate support and also with a small semi-compliant balloon. So I think that combination is the right combination for what perhaps some people may say are uncrossable lesions, is that the right guide catheter support with a facilitated balloon to cross this uncrossable lesion. And I think that the evidence is there from the Disrupt series of studies that crossability with the balloon was actually achieved in the vast majority of cases.
You've got a point, indeed, Jonathan. Let's not forget that the investigators in Disrupt cut were experienced colleagues, and you are one of them, who knew exactly the place, who knew exactly what was the right setting. And I think I alluded to that also during my talk and in the early part of the discussion. You know, everything starts from proper setting. I'm sure that many of those supposedly uncrossable lesions, if you have right setting there, right guiding catheter, coaxiality in your device, are not really uncrossable. Mm-hmm. And after all, each device should do its own job. The IVL balloon, the shockwave balloon, is not there to pre-dilate. It's there to modify the calcium. You should use other device to open up the vessel a bit. So then I agree with you, it should be combined with predil, gentle predil, because you don't want to see major dissection, in order to enable the shockwave balloon to go through. I take your point.
Now, across Europe, I know you're just about to assume your role as EAPCI president, and congratulations on that. There's a wide spectrum of calcium modification techniques used in the various countries in Europe. And I think you showed that very eloquently with the graph of the distribution of rotational atherectomy. But I'm intrigued by the data that you've generated from the IVL registry, and also that we've seen from Margaret McIntaggart about combination therapy. If you're going to make a prediction for what's going to be the ideal combination, what is the ideal pairing of IVL versus another modality? What would you say is that ideal combination?
I have to disclose that I'm biased by my. I'm quite fan of atherectomy tools, so it is for me an easy answer here. I would see lithotripsy or lithoplasty as a very nice combination, especially in the setting of uncrossable lesion. Really there, you know, we know that if we increase the bar size, we increase the rate of complication with rotational atherectomy. This we've learned it after decades of experience. So if we can avoid upscaling with the bar and just use the single ablation with the orbital atherectomy, soon you won't need to upscale with the bars, as you know, and then complete your plaque modification with IVL. That could be a nice combination. Whether we need in all the setting this kind of combination, I don't think so. Even the UK Italian registry showed that in up to 17-20% of the cases you needed that, and Margaret showed the same. The point is budget. We cannot afford to use these combination devices in all cases. So, but I think this could be a right compromise.
Great, Emanuele. Please stay with us for the live case. We are delighted to be joined by Ajay Kirtane from New York, who is joining Emanuele to help us moderate the live case. So over to the Bristol Heart Centre for today's live case with Julian Strange and Tom Johnson.
So this is just a case from Bristol Heart Institute. The patient we have today is Mr. S.J. He's a 71-year-old gentleman with CCS class 2 to 3 angina who had a positive exercise treadmill test. He has a background of coronary artery bypass graft surgery in 2012, where he had a Lima LAD and a radial to the right coronary artery. By way of comorbidities, he has type 2 diabetes, peripheral vascular disease with claudication at 50 meters, mantle cell lymphoma, which is under conservative management, and autoimmune hemolytic anemia, for which he's on prednisolone. His hemoglobin today is 110. He had an angiogram in 2020 at a local DGH. This showed patent grafts ×2, but severe distal left main interosseous circumflex artery disease. He underwent MDT discussion and was planned for elective PCI to the left main to circumflex arteries. This is his coronary angiogram done at the DGH, which showed severe distal left main to the ostial circumflex with quite a retroflex circumflex artery. They attempted to PCI as planned, and while they were able to cross the lesion with a 2.5 millimeter semi-compliant balloon and a 3.0 NC balloon, you can see that there was significant wasting. However, they were unable to deliver a 3.0 shockwave balloon to the lesion and therefore elected to stop. The patient was referred for elective PCI at the Bristol Heart Institute. However, he has been admitted in the interim with chest pain and a troponin rise in the setting of rapid AF and has had ongoing symptoms on the ward despite rate control. His echocardiogram demonstrates normal LV systolic function and is planned for inpatient PCI today. The objectives for this case that we hope to demonstrate are to consider the treatment of calcific coronary disease utilizing an algorithmic approach, to demonstrate the role of intravascular imaging in guiding and optimizing complex PCI, and to maximize safety for the patient and for the cath lab team as well. With regards to safety, we were going to illustrate the use of some radiation protection setup, including the egg nest and the adept starboard, and I'll hand you over to Tom and Julian in the lab now.
Great, thank you, Sanjini. So, I think this whole case is focused on not only patient safety, making sure that we have a nice, safe procedure. So we're using a radial approach here, but also safety for the whole team. And, that requires radiation protection. This gentleman's 95 kilograms. We know this is a relatively complex case. And so the EGNES technology, I think, will be very useful here in providing not only me some protection, but also the whole team as we move around, potentially use different bits of equipment. Just going back to you in the panel, should we just show you where we are and some of the setup shots?
Julian, that's a great introduction, and obviously it'd be interesting to hear your thoughts on the egg nest as well. But ironically, we've just had a great talk from Emanuele and a discussion in terms of what is an uncrossable lesion and delivery of the IVL balloon. So this case couldn't be better planned in terms of trying to show how you classify what uncrossable is and how you deal with those kinds of challenges. So I think it would be crazy for me not to ask Emanuele for his initial thoughts after that presentation.
Yeah. Yes, I swear I did not consult with the colleagues in Bristol. So it's indeed, it's a terrible angle. That's my first consideration. This left main circumflex is not an easy angle to overcome. So I thought after the non-compliant balloon dilatation, shockwave could easily go through. I wonder whether, but perhaps you have more experience than I have, I wonder whether some mothering child would facilitate this. But I guess the colleagues have already thought to that. And I can tell you, this is also the setting where I'm personally scared to easily jump to rotational atherectomy, because that is exactly the setting where your bar can get trapped. So it's an interesting case, very challenging. So open to see what they are
doing.
Listen,
before we get on to the mechanics of the case, Ajay, radiation protection, this technology is, I think, under the auspices of Bob Wilson, who's in Minneapolis. Are you familiar with this? What's your thoughts on healthcare professionals and their exposure to ionizing radiation?
Yeah, I'm not directly familiar with this. I'm aware of what it is and some of the other systems out there as well. But I do think that just like orthopedic injuries, which I'm intimately familiar with. It's one of those things where we don't really think about it until it happens to us. And with radiation specifically, what can happen to you is far oftentimes less reversible than some of the orthopedic issues. So my feeling is that the more we can emphasize radiation protection and safety, not just of the team, but to the patients as well, we're going to be doing better in the long run. And I just want to echo the comments made before about this specific lesion specifically and the delivery. It would be interesting to know what was tried before, whether with a balloon going up there, could a guide extension be brought around that area? Could you use a certain type of wire, like a wiggle wire, to get off a spicule of calcium? But this is all great problem solving. I think this is exactly what the audience wants to see.
So Julian and Tom, you've heard the initial thoughts. One of the questions raised really was the first case, you could see the aspiration. The aspiration was to use calcium modification, but the delivery wasn't feasible. So what makes you so special, Julian? What are you going to do differently?
Well, forewarned is forearmed. And I think with all of these cases, this was a query proceed that the operator went in and he was doing a diagnostic with a view to proceeding. Now, we know from the CTO work that we do is that actually looking at an angiogram of preparing yourself, having appropriate equipment leads to high rates of success. If we go back, and I don't want to be critical to the operator because, you know,
don't be shy, Julian. That's fine. It makes good TV.
No, but he set up himself to fail a little bit in that he proceeded into a complex case, which we've heard about. I really do not like left main intercircumflex lesions. They not only are challenging during the case, but they give us poor long-term outcomes as well. And, you know, he was 6 French. He was able to deliver a 3.0 non-compliant balloon. I think there's options with 6 French. If you can't deliver something, to use an anchor balloon in the LAD potentially to help deliver. I'm surprised that a 3.0 non-compliant balloon got round, but a shockwave didn't. And the comment about using a guide catheter extension is also very valid. I think once you've been able to deliver a non-compliant balloon, potentially you can deliver a guide extension, and that will lead to successful delivery of most bits of equipment. I think part of the reason for stopping was that he saw that he was getting himself into more complexity, and he was in a relatively safe position where he hadn't caused dissection. And he works not only in the district general, but he comes in as a visitor here, and he felt that he would be safer, the patient would be safer if he brought the patient here where we have more resource and more backup, and you could do it as a dual operator case.
So a smart choice. Listen, I'm going to ask my co-chair, Jonathan, about the goals of revascularization here, because interesting when you've got this so-called protected left main. We didn't see the Lima shot, but we can see sort of top right of the screen, the Lima coming in. So one of the questions is, what are your goals? I'll give this to Jonathan first of all, of revasc here, and what kind of weight are you going to place on that high diagonal? Because that's, I guess, you know, part of the question, you know, in terms of how we manage this left main bifurcation.
Well, so on my reading of this case, so you've got LAD protection, but you don't have diagonal protection. But the options here are your priority is going to be left main intercircumflex. And of course, you want to absolutely preserve and secure access to that osteal proximal LAD. The comments that I think were made about the combination therapies earlier we've had with from Emanuele, I think are very relevant here. Is this a case for combination therapy, or if we're very keen on preserving this bifurcation, do we use the anchor balloon option in the osteal LAD, proximal LAD, to drag your shockwave balloon into the circumflex? So I think that's I mean, here the priority is left main to circ. So whatever you can do to achieve that goal, I think you should focus on.
And it's a very interesting juncture, this, Ajay, in terms of bifurcation therapy. We've just had EPC published, and you know, it's sort of weighted towards provisional ahead of 2 stent bifurcations. So interested to hear your comments on that, and the weighting it shows the complexity of the weighting isn't always the same. This is a kind of slightly different scenario where the territories as Jonathan says, are certainly weighted towards the lateral wall here. So any thoughts on that study and how you would extrapolate it into this clinical environment?
Yeah, and also it's also interesting that we often think of CABG as providing complete revascularization, but in this case, the CABG completely neglected the circ, which is one of 3 pretty important arteries. So that's sort of the prelude, and then what you do with this once you've done the plaque modification, et cetera, it's a slightly different scenario because this is one where, yes, the diagonal is not small, but the majority of the territory that I think is of large interest is into the circumflex. So it would also favor this type of approach where you want to keep that proximal LAD into the diagonal open, but avoid too many layers of metal because if this is going to come back, as it's often is prone to doing, then that restricts your options later. So that's kind of how I read that data from UBC Maine. And also, I think that if we want to truly get the best result for both branches, then that's where people might argue, well, do DK crush, because that wasn't really studied in the trial. But this is a different scenario given the fact that the LAD is protected. The one quick final comment I'd also make, because Emanuele mentioned this in terms of burrs getting stuck, the ostium of the circ with this type of angulation and a bend is also exactly where you can get a perforation with atherectomy-based approaches. Yeah. By the way, that can also happen with balloons too, but it's something that we often do, but we do with trepidation, and having other technologies out there or modifications to atherectomy technology may afford safer options.
Listen, Tom, just a final comment before we get you guys head on into what looks like a complex case. I know that Bristol was heavily involved in October, which is another bifurcation study. And I wonder how that informed your approach with respect to bifurcations and how you would contrast that to EBC, because they're very, very different approaches, aren't they?
Yeah, so James, sadly, I'm only involved on a data safety board capacity, so we haven't enrolled because we were enrolling to Illumian 4, but I'm intimately aware of the challenges and the findings that Niels has been reporting, despite the fact that the trial's still got 100 patients or so to recruit. I think you know, the philosophy that we have in Bristol anyway matches the aspiration of October, which is an image-guided approach. And we saw beautifully in your last live case of this series with Richard Schlofmitz the use of imaging to guide our decision-making. Now, in some ways, we've been lucky to learn from that experience in that we have imaged now both the LAD and the circumflex limb up front. And all these comments about, you know, the use of adjuncts in terms of mother and child catheters, using more aggressive wires or anchor balloon placements, I think are all very valid. And actually, I'm pretty confident we would have got the IVL balloon down this lesion with what we've witnessed with this 7 French EBU 3.5 and wires down both vessels. But actually what we've done is we've taken imaging, and maybe we look at the OCT now, James, because it takes us on beautifully from the last live case that you ran out of New York and St. Francis. So if we show the OCT, maybe go big screen on that. So we're fortunate enough to be a center now using Ultron, the latest software. And obviously the main premise of that is the use of artificial intelligence to detect both calcium and the external elastic membrane. Beyond that, we've also just this week also stepped up to using the OpStar catheter, and I know that Richard showed last time round the use of Abbott's newest catheter, which has had refinements to its tip, making it more deliverable and more durable. And we've seen beautifully, if we go forwards, you'll see the OpStar in situ in the LAD, and then we take a co-regged pullback with 50-50 contrast saline, so we're minimizing contrast use. And then I can show you these OCT images. So let me show you the OCT image from the LAD. So the first thing, we're moved into this workflow of morphology, and orange equals calcium. And you can see here very impressively, the algorithm has detected very high burden calcium. Now, as we've already talked about, I think the issue of artificial intelligence is that we're constantly trying to challenge the artificial intelligence to beat it. What's interesting is we have this ability to shift the sensitivity. So at that point, I had it on at 60, detecting any calcium of a 60-degree arc or more. Now, as already has been identified in the seminars that have passed already, 180-degree arc is one that we're interested in. So if I bring the sensitivity up to 180 degree, what's really interesting here is we see the orange fade away. If you can see that on the longitudinal, if I enlarge that for you, there are just a couple of stripes of potentially 360 or greater than 180 degree calcium. And in actual fact, this demonstrates the complexity of plaque morphology, because I'm sure you'll all agree that actually we see, even in the absence of the orange arc, we see that there is very, very extensive, almost 360 degree calcium, some of which is superficial, some of which is deep. And then, as Richard highlighted, the third characteristic of calcium is potentially nodularity. And we actually see here in the proximal LED a really quite marked nodule protruding from 1 through to 3 o'clock. So we've got all forms of calcium detected in this LED run. Now, as we scroll back, and this is running into the diagonal, so you see that bifurcation. Here we're moving into a smaller caliber diagonal. If I shift back then to here, the bifurcation point right at the carina, we see the circumflex. I'll just reduce the longitudinal. You see the circumflex wire is down at 6 o'clock. The LED wire is in situ around the OCT catheter. And the AI has only detected 2 small quadrants of calcium. In actual fact, this is encased. So as we scroll through, we see very, very tight distal left main. And again, calcium that's almost circumferential, but not quite detected due to the complexity of plaque morphology. Come back into the left main, and we see a left main that luminally is about 3.5. EL to EL is probably 4.5 to 5 millimeters. So if we shift to the circumflex, impressively, the OpStar made it through to the circumflex. So I can show you now the circumflex run. And here, again, you see now on the settings of 180 degrees, the longitudinal would suggest we've got very little in the way of calcium. And yet at this point we've started, we have almost complete encasement of the vessel with really, really thick. So if I make a manual measurement of this calcium in terms of thickness, one of the 3 parameters we use for prediction of stent under expansion, this is 1 millimeter thick. Okay, we've got another layer of calcium on the superior surface of that, which is very high, masked also by some soft tissue, which would be an interesting discussion point in terms of the IVL. As we scroll down, so I'll just bring you back to the level of the left main into the circumflex. I just try and get this to work. That's good. If we scroll down now towards the bifurcation, here we come into the circumflex. Look at that nodule sitting, protruding from 6 around to 8 o'clock, right at the level of the carina. And I have to say that our interpretation of this, although I think we could get IVL down, we feel very strongly that there's probably the need to do a combined approach here, that we want to perform some debulking. We don't want to be in a situation of rotor regret in 30 minutes' time. And yet with this huge burden of calcium, we cannot believe that rotor ablation is going to be sufficient to adequately modify. So we're expecting rotor up front, followed by IVL, to get the optimal result in terms of the calcium. I'll hand over to Julian.
Well, I think also, all the comments about the jeopardy of rotablating around left main into circumflex are heeded, and it's something that I don't particularly like doing at all. So we're going to be cautious, but I think, as Tom says, nodules are potentially going to cause perforations if we try and optimize our stent as well.
Yeah, no, it's a good point, Julian. And actually, what were the measures you're going to take to minimize the risk of perforation here?
Yeah, cautious rotablation, small burr, and just making sure that, people talk about different wires. Are we going to take a rotor stiff or a rotor floppy? I don't personally have an opinion that I think makes any difference with that, but I think I'm not going to take a large burr in. Normally we would size to 50% of the vessel, so we'd take a 175 or a 20 burr. We're not going to do that. I just want to get some modification. Some disruption. We'll use a standard burst speed first. We would decelerate to see if we can get a little bit more debulking of these nodules, and then we shall stop. You've actually got a bit of bias away from the nodule there, haven't you? And that's still what we can see.
Well, so James, no, actually, so I was hoping to highlight that there, just making a measurement. So you see where the OCT catheter is embedded, and the wire just to its left at 9 o'clock, that's the circumflex wire. So actually, if we were on the LED wire down at 4 o'clock, then clearly I think a burr would just fly through without making any contact. We've actually stepped up to a 1.5 rather than a 1.25 burr, but would be fairly hopeful that through the bias up to that 9, 10, 11 o'clock quadrant that we will get contact. The other element to that is once we've safely negotiated is then to potentially reduce the burst speed and gain greater reverberation. You know, we don't have CSI, we don't have orbital atherectomy, but one of the things I'd really like to do is test it, because Richard was talking last time about shaving off the nodules. That's our intention here, is to try and debulk as well as modify the calcium sufficiently for stent expansion.
And it's interesting.
Tom, sorry.
You go ahead, Jonathan.
Tom, just wonder if you could just show us with the co-registered view exactly where that nodule is. I mean, there's really beautiful demonstration of the detail of the calcium. So just...
Do you see the marks? I'm afraid we don't have a mouse now, Jonathan. As you know, there are some frustrations in terms of Ultron, but you see those two diamond sort of needles that are coming up the distal left main, and there's a dot just below it. That's where we're at. If I scroll up and down on longitudinal, you'll see it move. There you see it move behind the two pins. So it's right at the distal left main, just prior to the true carina. Yeah. You see the LED just duck out there at 3 o'clock.
And just comment on how easily did the OpStar catheter go in? Is it? Yeah. Is it very?
It does feel very. Yeah. So it feels very different. It feels user friendly. You can feel there's a difference. There's a robustness to it, and there's certainly a deliverability. I mean, it's a different beast. So it's made a difference. I'll be interested, coming back to the panel, what they would do here. Because you've heard from us.
I'll maybe flip this back on Emanuele, because I know, Emanuele, you're a big fan of rotational atherectomy. And I'm sort of reflecting on how our goals of rotational atherectomy have changed. You know, initially we were talking about debulking, then we moved to an area of actually just facilitation of secondary equipment. And now we seem to be going back to debulking and facilitation of secondary equipment. So what are your thoughts on the proposed strategy from Bristol and how you would use rotational atherectomy here?
I think I agree on many of the points that were touched upon by both Julian and Tom. A touch of rotablator, and I use on purpose these words, a touch of rotablator, I wouldn't do more than this, can help in minimizing the risk of having perforation. I'm not saying zeroing, because we have no magic ball to prevent it, but at least would give some control on this procedure. You see that the setting is completely different from the one that was used the other time. They use a much more robust guiding catheter. I suspect that already with this setting, if they would try IVL as a first intention, that would be able to cross, but that's not the point, as it was nicely highlighted. The point here is really to start modifying this plug carefully. I agree also with the choice of the bar size, not too big. The goal here is really not to make massive debulking. Disangulation, as I said before, is challenging, and in this case, a small bar can reduce the risk of having problems there, of bar entrapment, perforation, and so on. And I agree with Julian that having a regular floppy rotor wire would be sufficient in this case, because if anything, a stiffer rotor wire would only increase the wire bias, which is not something you want to pronounce even more. It is already enough bias, this wire, so you don't want to do that anymore. And I'm not concerned at all of losing the proximal LED. There's a wide angle, there is a wide ostium there, so I don't think there will be an issue of losing the LED there.
Change the camera to the rotor.
Ajay, you've been involved with orbital atherectomy. Do you see a role for orbital atherectomy in combination with shockwave? And is this one of those ideal cases?
It'd be nice to capture.
Yeah, I actually first would echo all the points Emanuele made, because they're sort of applicable to both forms of atherectomy. You know, using a floppy wire, going slow, don't go too big. Those are important things. For me, this is a case that can be done with orbital atherectomy. But the advantage of orbital is you can sort of glide assist through, and then you can actually do the debulking or the modification of the nodule on the way back. And that is often preferred for these types of angulated lesions, because back when we first had orbital with a stiffer wire and people were only going forward, as I said before, this is an area where you have to be very, very careful about the risk of perforation. What is still unknown is whether if you do something like orbital, do you then need to further modify the plaque and crack it deeper with a device like IVL, or is an NC balloon sufficient? We just don't know those things. What I would not do though, is I would not go to high speed, even if I'm doing it on the way back. And the idea for doing any type of atherectomy in this case is because of the nodule, and that was so nicely illustrated by the imaging, which is a prerequisite to this type of case. And OpStar is great, and this is what we need to do to look at calcium, because if you're trying to use a standard IVUS catheter that won't cross this, you'll never get this type of information, and then you're sort of flying blind, which is more risk for the patient.
I think the essential point of the combination here is superficial modification with atherectomy of orbital or rotor, but really the only tool that's going to give you that deep wall calcium modification currently is IVL. I mean, James, you're doing the left main stem trial.
Yeah, we're obviously mugs in that we're doing left main bifurcation using IVL. My kind of comment here is really about the pathology around cranial plaque, in that the reason why it's so difficult to modify the ostium of the circ is that the wire is intrinsically biased away from nodules all the time. Mm-hmm. It's not just on individual cases, because you don't get much plaque on the opposite wall of the carina. It's the inferior wall that you have to modify. So I think, we do have to be careful in how we apply these technologies. We don't have your experience with CSI, Ajay, but I'm kind of intrigued by its kind of elliptical kind of course, and it should make more sense. And I think actually we're learning from our Japanese colleagues about how to apply similar elliptical courses for rotational atherectomy. So, Julian, with that in mind, I see you've crossed at 150 revolutions per minute. Thoughts from here?
Yeah, so we've done 3 crossings. Two crossings. The first one we just did a short run to see how the patient tolerated, and actually the burr wasn't passing into the circumflex. The second one it did. The third one it did with not many decelerations. We are going to, as you suggested, we're going to reduce our speed now down to about 110 revs per minute, and hopefully get a little bit more of an area of debulking. And Tom just wants to...
I've got to show you another bit of OCT.
He can't help himself.
So James, just to accentuate that point you've made, because that nodule that we were focused on is in the left main proper. It's not at the circumflex. If you scroll down more, as you see here, the catheter, this is at a small side branch at 6 o'clock, and the bulk of the AV circ is in the higher quadrant. And you see, as I scroll back up towards left main, there's that nodule, and the catheter is away from the nodule. So obviously the arc of the catheter is onto the upper curvature, and the nodule is on the lower curvature, albeit on the top of our screen. Yeah. So you're quite right that the biasing of that.
Yeah, this makes the point exactly. Yeah. Beautiful images, Tom. Really.
But then thanks, John. So the reality is now, though, that we're going to reduce this burst speed to 110. I think it would be interesting if you get it on the audio that you do absolutely hear that increasing reverberation and hopefully contact with the calcium, which is what we're trying to achieve. And the Japanese bio-OCT have shown fantastically, increasing the debulking area by 200, 300%. Yeah, this is a 1.5 burst. You see the stall sign coming up occasionally, but it's actually running fairly smoothly. You'd only do this having undertaken those multiple runs.
I think that's absolutely right, Tom. That's a great point for the audience, that you've got to pass at high rotational speed first of all before you decelerate, because otherwise your risk of burr entrapment's higher.
Yeah, although the paper, the study, it was a small series, but there was a 0 stall rate. The other concern would be at a lower rate, you might have a greater risk of no reflow. And again, that wasn't observed.
Yeah, why do they say that, Tom? Because obviously platelet aggregation is a heat-dependent phenomenon, which is higher at higher speed, not lower speed.
Yeah, well, I think that the no reflow may be a combination of both distal embolization of debris and the concern that maybe at a lower speed you're creating larger debris material. I don't think it's understood, James, honestly.
Yeah.
But maybe the time
is now for.
Ajay, you were going to say something there.
No, some of it may be the time too. If you're sort of going slower and having longer runs, maybe that's what some of it has to do with. But we need to refine this technique, because it's the risk of stalling and capture of the burr is certainly there. That's for me why I think if you're going to do this type of slow run to do more debulking, orbital can be favored if you have it and have the experience, but albeit with the caveats mentioned about the risk going around that bend.
Emanuele, I understand that you've got to go, so we'll thank you for your input and your great talk, which has set up the guys in Bristol nicely for what looks like it's going to be a challenging case. So thanks for that, and I hope we get a chance to see you soon.
Thank you. Thank you very much, everyone.
Thanks,
Bye-bye.
Emanuele.
Cheerio.
Great to see you.
So this is a nice new feature. It may not actually play brilliantly, but in terms of this ability to make comparison between two runs, so we've got on the top we have the pre-rotablation circumflex run, and on the bottom we now have the post-rotablation run. So it's interesting where you see the modification and then the potential thrombus formation that's evident, but we've made a channel there. I will return to the full frame because I think it's probably more instructive, but it is a nice new feature of the software.
Tom, can you actually measure the diameter of the channel?
Well, so yeah, I can. I'll do that in full screen, Jonathan. The frustration is you can't then make an area measurement. But,
no.
You know, that's the nodule. The catheter now is in situ over that nodule. If you remember that morphology we had.
Yeah.
And so actually we have taken out some. We haven't shaved it all off, but we have done what we set out to do. But most importantly, that issue about rotor regret, this is where we'd have IVL regret. You know, you've gone through the stress of taking a 1.5 burr, worrying about the jeopardy around the circumflex tortuosity, stalling, perforation, and then you say, well, we're done. We're going to balloon and stent. Now, if you ballooned at this point, in the vertical projection, you're going to get a 3 millimeter balloon expand completely. And yet you see that calcium from 9 o'clock round to 6 and then extending into that incredible volcanic type nodule that's then we've taken the top off. We are not going to have adequately modified to, as James said, overcome this potential weakness for durability and long-term result in terms of circumflex expansion. So this combination therapy, I think, of the rotor debulking and then the IVL for the deeper calcium, the thick wall calcium fracture, we hope, I think gives us then the chance of the best long-term optimized result.
Tom,
it's a great OCT example too.
I know
polishing. Akiko calls it polishing of that nodule, which is really nice.
But I think it's fair to say, Tom, I mean, these are really exquisite pictures. I think if this type of case, I mean, in this case in particular, I think should convince everybody who currently is predominantly using IVUS for the distal left main, for the left main bifurcation, that you really cannot get this exquisite level of detail, this level of information. I mean, it's phenomenal. It really,
it's exciting, isn't it?
Yeah, these are brilliant pictures.
I think, you know, we have evidence. I'm not sure it's great evidence, but the IVL works better when it's not severely constrained as a balloon. You know, you get better.
Yeah, we've got bench data on that, Julian. It really does matter. The emitters if they're compressed, they don't generate the same degree of shocks, and of course you also risk the rupture problem if you've got a very kind of craggy nodule. Hopefully now your problem with delivery is certainly gone. And you can concentrate on optimization here.
Yeah. So we've done that on a rotor floppy wire, delivered the OCT catheter. We're now just trapping out with a trap it and using a caravel just to do a nice quick exchange. It's a step people may think is unnecessary, but I think it just is a level of safety again. It's something that we've adopted, trapping and exchanging wires.
And what about the LED? Are you going to put a wire down that, Julian, or are you planning to rotablate that?
I don't think we don't need to rotablate that.
Yeah.
But actually, we have a pretty good area at the ostium of that LED. So, do we need to actually? What's our final strategy? What's our stenting strategy? We are going to potentially just use a single stent, left main into circumflex, and drug-eluting balloon out into that LED, and hopefully maintain a good minimal luminal area and flow that down that diagonal with minimal disruption. So
you see, this is the proximal LED that you're seeing on the OCT in the lower left quadrant. And so you can see actually the ostium here of the LED is relatively, obviously it's heavily diseased, but the lumen is relatively clear. I can't give you an area, I'm sorry. But the reality is we have a decent lumen area there. It's at least exceeding 6 millimeters squared, I would have thought. We then have that nodule, and actually if we're going to embark on the LED, I think we're going to be in the same place where we're going to have to think about a debulking strategy rotor here for this nodule. So I think with this in mind, and we wouldn't get this from just the angiogram, I think this pushes us towards knowing that we have a lemur that's protecting the majority of the LAD, not the diagonal, that we're better off probably trying to take a drug-eluting a balloon strategy to this LAD, avoiding that need for modification down both limbs would be my preference.
Point and note, and I'm going to ask this question to Ajay, because it strikes me that the pathology explains a lot of our clinical sequelae when we look at failures of left main PCI. That bias is towards nodules in LAD, so you'll naturally treat them. You can see the wires right against this nodule in the LAD, but the circumflex is biased away. Do you think that's one of the reasons why we get, because of the way plaque forms, one of the reasons why the ostium of the circ tends to be the failure point?
Yeah.
It certainly can be. And one of the challenges also is that there's so little imaging that gets done, that this concept of a nodule is only something that was promulgated in the last 5 years or so more broadly. And so I think with the recognition that there are different types of calcium, there are morphologies that are different, the thicknesses are different, the characteristics are different, and how that impacts outcomes. This is only now starting to be more prime time and talked about at meetings. Before it was very niche. So I am hopeful that with the identification of these types of morphologies and then potentially changing your treatment algorithm based upon them, we could hopefully overcome the notoriously poor outcomes that we have in this area.
So we are, I'm just going to put a wire down the LAD. Great advantage of IVL. You can wire 2 limbs, no issues there at all. That will allow me, if we have any problems with delivery, to use an anchor. And then we're going to take a 4O shockwave based on the measurements we've got from OCT.
One question I have, and this is great, is remember the prior case, it sounded like a smaller IVL balloon was being attempted and that didn't succeed. And now you're using an image-guided 4O balloon. Jono or James, want to talk a little bit about the field effect and how that's important in terms of actually modifying the deep calcium, and it's not just a throw a balloon in there and it's all going to be the same independent of the size of the IVL.
James, why don't you take that?
Yeah, so firstly, the most important thing in terms of efficacy is apposition. You need to have a balloon which is full properly, prepared properly, so the preparation of the balloon in terms of contrast is really important. Otherwise, you'll get a marked attenuation effects if you come across any sort of gas in the balloon. So the preparation is really important. And beyond that, it really is apposition to minimize any dropout between the balloon and blood. Blood would be a killer in terms of transmission for shockwave. All the forces would be lost there. And I'm not totally certain sizing the balloon to the EL makes a lot of difference if it's sized to the lumen.
As long as it's opposed.
Yeah, it needs to be opposed and sized to the lumen makes a lot of sense. And then in terms of how well we penetrate deep tissue calcium, probably is a dose-dependent effect. And I think there's a lot of basic science and base testing that we actually don't know in terms of volume of calcium and number of pulses that need to be delivered. And it's one of these questions that we're still wrestling with. How do you know when enough's enough? How do you pulse management? How do you know when after 20 pulses, if the balloon goes up, is that enough? I suspect concentric calcium actually makes things a lot easier because we know that actually if the balloon goes up, we've fractured the calcium enough for the stent to go up. It's eccentric calcium where adventitial stretch can actually hide a real basket of sins, a Pandora's box, if you like, where you get overexpansion away from the calcium and you don't modify the calcium. So if that's the area, I think where more questions still arise. But, getting back to your question, apposition is the key marker of IVL efficacy.
So Ajay, there's really some...
Can I just get you move in a second? So this is just the 4O, just going back to Ajay's point, this is a 4O shockwave balloon and it passes easily. So, has rotablation made a difference? I think so, because there's nothing holding us up here. We're now in a great position. I'm just going to go up here.
Happy?
Yeah, 4 atmospheres.
Okay,
so some
constraints.
Sorry to interrupt.
Distal segment,
Yeah.
But good expansion, actually. But you see some indentation at the tip, probably in an orthogonal projection. There may be other indentations. So Ajay, going back to the point about with the deep wall calcium, there is definitely a dose effect. Apposition is important. So Renu Vermani has been doing some really beautiful work looking at this field effect, how deep does the shockwave field penetrate into calcium, and really some very intriguing data emerging looking at with micro CT is that even though you may not see the macro fractures, the superficial ones that we're looking for, and the going from the intimal layer right through to the media, you are seeing lots of micro fractures very distally, so at a depth more than 1 millimeter through calcium blocks that are extremely thick. So I think the field effect does extend way beyond the outer layer of the balloon, and then millimeters beyond that, and you can evidence by presence of microfractures.
I think the other thing to say is, obviously, when you get an effect, you also get dissipation of energy, which is why you have to keep giving the same level of energy. So it does make sense that the thicker the calcium, the kind of almost the dose dependency increases as well as the deep wall element of the calcium. But as you say, Jonathan, previously, there isn't really a competitive technology in that space where if you've got deep wall calcium, you need to modify, you don't have an option.
So even in the presence of full expansion with this 4 millimeter balloon, I would be recommending that they deliver all the shocks that they can to that area of maximum calcification that we've seen on OCT. So the full 80 shocks. And the new iterations of the balloon, as we know, the peripheral balloons have up to 300 shocks per balloon. So, the next iteration of the coronary balloons will potentially deliver more shocks and potentially more energy, which I think may have some relevance in the left main.
Okay. Yeah, so just a little bit of fentanyl, please, and a bit of Madaz.
So what did you do in terms of pulse delivery there, Julian?
So we're now on 40 sets of pulses. We've been moving this balloon, and it moves really very freely back and forth. So even an unwrapped shockwave is now passing really easily through all this left main ostial circumflex territory. I'm just moving, and what I'm doing by hopefully doing this is getting maximal energy over several different points within this circumflex left main territory. And, as Jono said, and we all know, we just want to try and modify as much as possible this.
Come back, because it's actually in
this deep wall.
And just a pointed note, Julian, I noticed you were taking the balloon out. Was that a patient tolerability issue?
Yeah, just actually less me not liking the look of his ECG. So we're occluding his left main. He gets nice deep ST elevation. I just wanted to make sure that we weren't compromising. We got great blood pressure throughout this. I just wanted to give him as much breathing space whilst we're having a little pause for a minute or so. So he's tolerating it really very well. He's a little bit more stiff than anything else from being on the table a bit too long. But you can see there the ECG is quite ischemic. It recovers.
A little bit inferiorly as well, actually, Julian, as well as laterally. So his right is occluded, or?
No, right's good.
Well, big cert really, isn't it? So maybe it's that.
So I'll do it more back, actually. It's just
in that we know, and that's the beauty of the imaging again, is that we know about where we want to be deploying the energy. I know Richard made a lot of that in the St. Francis case. Again, without imaging, we might think, well, let's take it down the LAD as well, but we don't have calcium that requires that type of modification at the ostium of the LAD or into the proximal segment, so we can focus solely on the circumflex and left main.
So Tom, you're planning then drug-luting balloon for that, the ostial segment, or is the?
That's what we considered in the first instance, and I think that the imaging, if anything, persuades us even more that that's a sensible strategy, unless we feel we need to embark on additional modification of that nodular disease we've seen in the LAD. I mean, it's a protected segment, albeit the diagonal is not receiving probably adequate supply. So we want to save it. We don't want to lose it. But I think complicating it with a second layer of stent is possibly a step too far in terms of durability of the overall outcome.
I wonder if I could ask a question to Ajay and James, what they think is the major limitation to durability in the ostium of the circumflex. Why do we have such a problem with the ostial segment of the circumflex when we're doing left main intervention?
I mean, so many things. We had talked about some of them before, about the nodularity, the angulation, the coverage of the carina, particularly with open cell stents. There's hinging that can occur, motion of the cardiac cycle, any and all of these things altogether. I do think, though, that the modifiable portion of this it relates to plaque modification and inadequate plaque modification and lesion preparation going in. And so that's the reason why the way we need to do these cases is to do everything we can to optimize prior to the stent deployment, so as to therefore get the best outcomes. The reason I, by the way, had mentioned about the size of the balloon is, I think, to James's point exactly, if it's opposed, you're okay. But if for instance, it releases as you're doing it, and you have a segment that's undersized relatively, your field effect is going to be smaller than if it were completely opposed throughout. And that's, I think there's a manuscript in press in the periphery, looking at IVL in the periphery, that sort of illustrates that point of trying to get an optimally sized balloon from the get-go. So as it potentially starts releasing, you remain opposed and continue to deploy those pulses deep.
Yeah, I'll be slightly more provocative in my answer to why the circumflex is a failure point. I think often we've described these questions in terms of mechanistic rationale, and there's no question that the bias effect is an issue in circumflex. But probably the major reason we don't get the same result in the ostium circ is behavioral factors. We think it's of secondary importance. We don't prepare lesions properly. We don't image lesions properly. We concentrate on the LED ahead of the circ, and the circ is kind of, well, it's open, so it's fine. I think that lack of a systematic approach is probably the dominant reason ahead of all those mechanistic reasons.
So this case, where the decision has been made that we're prepared to focus on the circumflex, this is the primary target.
It's reverse engineered. Yeah. So if you're going to say what's likely to be the failure here downstream, you would say it's more likely to be the diagonal than the circ.
Right.
Just have a look at this fluoro grab, because we've talked a lot about the deliverability of this OpStar catheter. This is the weakness of the previous iteration, was around that circumflex. Now, historically, if you'd pushed here, it would just buckle and prolapse into the LED. This is a 4.0 NC balloon.
Can you talk about the importance of this inflation? I know that there's some controversy here. There's some folks who will just do IVL, and if it expands, then just image or even just stent, versus doing this inflation specifically. I think it's a good important point for the audience.
I think Ajay, we were going to take the imaging probe for the purpose of demonstrating the sole effect of the IVL, but we absolutely anticipated the need to postulate this more, maybe even with a Wolverine to further modify. But it's critically important. You can't just take the angiographic expansion of the balloon as adequate modification.
Yeah. But Tom, do you not think that part of the deliverability reasons, especially going around this angulation, is actually because you're just catching on modified calcium, that you're able to pass it prior to calcium modification, certainly, but when the moment that you start cracking things, then it's those cracks and those edges which then impede the progress of the catheter, whether it's an OpStar or the previous generation.
I think that's absolutely right. I mean, if we just put up the OCT again in that lower left panel, again, the imaging explains all those difficulties. You look at the different shelves and kind of crags of calcium there. There are a whole host of different areas where devices, nose cones of balloons will get caught. So, and each time we take a device, we're changing the morphology of that again. So you have to expect the unexpected with every step, I think.
So sorry, I didn't introduce our team here, and I've just been told that I can't have the OCT catheter until I do an ACT, which I'd like to introduce the team in Bristol. We've got a fantastic group here who are helping us deliver a safe case, and that was my weakness. So we have Joe as a radiographer, Katie as our technician, Sylvia and Hyan, who are all here. And, I just love it when they put their foot down. We need an ACT, you're not doing any more. Okay, we'll give you an OCT.
It's a very good example of safe practice and the importance of the team, and obviously you're doing your best to protect them with that modular radiation system as well, which is, perhaps should be more at the forefront of discussions for all our staff. So well done with that. But that is an interesting point about, you know, the difference barotrauma you get from high pressure inflation versus what you're doing with IVL therapy, they are different. They can be complementary. You know, perhaps if you got complete modification with IVL, you wouldn't need post-dilatation. But it's one of these unanswered questions really at the moment.
Jana, what do you expect to see? Big fracture planes, a spicule, residual nodule, all the above? What do you?
I think it's going to look quite unpleasant in there. There's going to be lots of crags and shelves, and there's going to be, you may see the gouge from the rotor. You'll see the cracks from the IVL, and I think it will look, you know, maybe look a bit like sort of crazy paving, but that you've clearly got full balloon expansion. It's just that I think the next step is going to have to be, well, lovely, look at that.
Guide extension delivery, normally I would use a balloon to deliver, but that went around and there was no pushing at all. So, you know, if it goes, it goes. And I think, of course, if there's any resistance, we take a balloon to help inchworm it forwards, but we don't need to in this case.
I suspect there must have been a bit of trauma to the OCT caster because it was going before you modified it. So.
Yeah, but James, we've also opened up the ostium to the circ.
Yes,
so
that's right,
in principle, we changed the tracking, and so the tip of the OCT is then just embedding distal curvature.
So if you go,
I think there's lots of reasons for why.
Tom,
let's have the OCT up.
Have you got your laser at the same point? Are you down to the same point?
Maybe just a bit further.
Just so you can do the line up. So.
Yeah.
Let me see.
We can bodge that.
It's what it is.
Happy?
54
mil. Yeah. Yep. Okay, that's good.
Yeah.
You're happy, Joe? We're open. So we do a pump injection manual pullback, very similar to the St. Francis module.
Inject.
So acquire, inject. Okay. Slightly slow. Yeah.
This one really had a little bit less contrast. I think we're okay. We just come to pressure there. We can maybe do another run actually.
Are you on a mix, Tom? Is it
50?
You're on 50-50. Okay. Mate.
Which I have to say works well. I mean, we don't have any issue with contrast in terms of volume of contrast for the case.
No.
That we haven't got great opacification in this instance. I think we've got
might be because the lumen is so much bigger.
Yeah.
Because it actually did look like everything released very well. And the cases of when you do post-IVL OCT, it's often very impressive. I mean, it almost looks like a bomb has gone off within that segment, so which is indicative of the effective plaque modification.
Yeah, so let's have a look. So scrolling down from left main, so with lots of blood swirl, into, so we still got 2 wires. So there you can see a small indentation at 4 o'clock.
Yeah.
Clear intimal
crack there.
Kind of pulling away at 12. You've got a crack there at 4 o'clock.
Just stop there.
And, you know, look
Tom,
at that. That's
what a beautiful example of an eccentric crack. So right through. I mean, I don't know if you can magnify that up even more.
But, you know, that's 1.5 millimeters of calcium depth. Let me just zoom that in, Jonathan.
Yeah, beautiful.
So, yeah, it's impressive, isn't it?
Mm.
Let's just discard that.
For those of us who like that kind of thing.
Yeah.
I'll keep you going over the weekend, Jonathan.
This is,
So that fracture you see extending, so that's extending over a great length. It's now hidden behind the guide wire.
Yeah, there goes
you see all
the
of that intimal trauma stripped off at the shoulder points of the calcium. Here you've probably got a fracture there at about 2 o'clock.
Yeah. I think there's one on the other side as well, about just below 9 o'clock.
About 9, yeah.
Yeah, and at 12 o'clock, there's further disruption.
Yeah.
And if you think of, I mean, this is probably where actually that comparison run
where's the
quite
nodule?
nice. So let's just bring that up. Now that's before, that's after. That's clever, isn't it?
Yeah.
So, so the nodule was in the left main, if you remember. So we've shaved the nodule in the left main around this point.
Gosh, quite a close shave then. It's gone.
And let's just pull that.
I think it's still there. It's just not protruding in,
Nice.
and it's polished. So the expansion of the balloon really helped. This is, I mean, it's a pretty impressive OCT.
Yeah, yeah.
Let's just focus on that. That's the most critical point in circumflex, which is where you see how massive we've now made that lumen.
Yeah, yeah.
With that restraint on the top panel, you see the restraint of very thick wall calcium on that lower left quadrant and upper right quadrant, that it's kind of really sandwiching the lumen.
Yeah.
And yet with the combination then of the debulking and the 4.0 IVL, we've got a fantastic opening to that circumflex.
Could you just magnify that view for us, Tom? Just
So I'm going to have to probably come out of this then.
And could you give us a measurement whilst you're doing it?
Yeah.
So I'm just...
So we'll just let's just.
You're actually doing the work,
we have to
Julian.
do morphology.
Well, I just would like to know. So I'd like to know next steps.
So we're just going. Let's use the sizing panel for making an appropriate size. We're not going to be able to do it so well because we haven't got such great opacification. If we,
you can use the first run. Can't you?
use the first run for the EEL.
I'd already done that on the first run. So here, this is what we initially planned, a 16 and. So device, we may want to talk about stent selection. We have our own opinion here. So you see that we have eccentricity to the lumen of the left main. So I think it's important to think about our landing sites. You know, clearly we want to be trying to land into a disease-free or disease-free as possible segment. That calcium, so we're looking at the middle panel at the moment of the three. You can see that there is this large calcific area from 2 o'clock round to 6 o'clock, thick in terms of depth, not really causing any luminal contour. And we're going to end up having to land into some of this calcium. So here we see the blood swirl as we come back to the ostium, and that calcific nodule extends right the way back into the aorto-osteal junction. And we have this eccentricity. So we don't have an external elastic membrane measurement there, but it's giving us, this is one of my criticisms of the current iteration of the software, is it's giving us an averaged lumen. And actually, I want to know maximum and minimum, because there's a profound difference in this highly eccentric vessel that we see actually in the longest plane. It's a 4.5 vessel. And it's going to be, 3.0 in the shortest. We're going to take a 4.0 device, undoubtedly, and having made the measurement distal, it's a 4.0 vessel in the circ. You know, it's 4.5 by 2.5. So in terms of length, then let me just remove this, keep those.
Tom and Julian, did you treat that left main in terms of?
Yeah, IVL.
Yeah.
Yes.
It looks like you know, if you're going to get a 5.0 result, you're going to have to have treated it really.
Yeah. So the issue we have then is going to be between a 16 millimeter or 20 millimeter device, giving you a hint at what we think is the device of preference. And we see here beautifully the AI in terms of visualization of the EEL, which is really impressive. So that white dotted line, if I pan off and on, you see it's estimating the EEL of 4. You downsize that. I think we're looking at this being a 4 millimeter rather than a 3.5.
But Tom, with that oval ostium of the left main, or on that proximal segment, do you think there's any rationale here for having a device with greater radial strength that you may sort of convert from oval to a bit rounder? I'm not sure.
As we hinted by 16 and 20,
we're
thinking Megatron here, Jonathan.
You're thinking Megatron. Good. Okay. Ajay, do you have Megatron in US?
Tom,
we do. I thought you were referring to the BX Velocity stent initially, but we do. But remember that
Ajay, why stop there?
Exactly. No, we do, and I think that for these types of cases, it's intriguing. I think we do need some head-to-head data, and the limited experience that I personally have with it, it can be great, and there are also deliverability issues that are reminiscent of those days that many of our audience don't probably remember. But I think it's a good choice in this case, particularly given the issues of, or the fact that you can size it very nicely, both distally and proximally, because of the expansion profile.
I'll choose your pop balloon off first. So
Julian,
the element here is now anticipating.
So exactly. So what I'm thinking of now, so we've selected our length, 20 millimeter. We're taking a 4.0. It's a little bit big for the distal vessel, so we're just going to go up to a low nominal pressure. We're then going to have to pot, and what Tom's going to do now is giving me my pot balloon sizing as well, and we will pot this, then recross, and then image, having post-dilated the whole stent, and then make a final decision about kissing and what we're going to do into that LAD.
Julian, you've used the Megatron, and I think you've got fairly extensive experience. Do you find there's any difference in deliverability in this type of angulated lesion? Is it very deliverable?
Yeah, I think it's probably because you're forewarned. You think, it might be challenging to deliver, and it never is. I don't see it being a major issue for this. Yes, it's thicker struts, etc., and you'd imagine it is going to be more challenging. But I think because we prepare these lesions, where we use Megatron is lesions that we've prepared well, and therefore there's not an issue with deliverability.
And proximal, Julian. But, of course, there is a difference. And, we have to understand that equipment is all about trade-off. If you want increased stiffness, increased radial strength, you get reduced compliance. Yep. That's just part of the deal, really. So as you say, I think the major difference is now we prepare lesions properly. So we restore vessel compliance, and therefore deliverability, particularly with the aid of guide extension, shouldn't be a problem. And if it is a problem, we probably haven't prepared them well enough.
So we're just coming around. What I don't want to do is have this hanging out, and it is obviously there a bit, so I'm going to go forwards.
That's a nice view to show that iliocranial view to show the ostium.
And it just shows your angular takeover. We discussed. Oh yeah, see there.
In a bit.
And we're not actually too worried about the ostium of this left main from what we've seen on the imaging. I'm liking that.
Yeah, that looks better, Julian.
Can we come to the original view and just see if this gives us, because this is the 1027, 10 REO27 caudal. So on that lower left panel, you just see this is the deployment mode of the Ultreon software, which should then give us the placement according to the measurements that we made in the sizing panel. It's just not coming up at the moment.
Which is the corner there, yeah? Isn't it?
Yeah, so that's good. It's just, so let me just come back to that sizing panel. I'm sorry.
Tom, what's
also nice, this vessel is huge distally, but you could even with the Megatron use a 3.5 and still get the prox up to 6. So it's it's nice to dial it in that way.
Yeah, it's probably.
This is showing really nicely in terms of. So on that lower left panel of the OCT, you see that marker, which is where we've made a mark on our sizing page of Ultreon, where we think we should be deploying our stent. And so we can be really confident working in that same projection that we're in the same place.
Nice. And we are, basically.
Yeah, we are very nicely.
So this is one of the new features of Ultreon, isn't it? This side-by-side comparison. Nice demonstration there.
So I'm happy. 2 views. We've got OCT confirmation that we're happy position-wise. I'm going to deploy here.
Julian, just as a point in terms of kind of behavioural factors, what does it feel like to have all these multiple extra steps in your procedure? Are you getting a bit twitchy, or is it working out for you okay?
Listen, you and me, James, have worked a lot on CTOs, and the reality is we go into a different zen when we're trying to achieve good outcomes for our patients. I think most of the time there's a degree of mania in my behavior anyway. When we get into a cath lab, I think actually my behavior changes, and I like this methodical, stepwise, teachable, algorithmic approach where it's not just hit and miss, it's not guesswork. And I love working with Tom because actually the synergy between us, there we go.
It's a beautiful thing. It's a beautiful thing.
You're getting very, making me, get a little weepy here.
Yeah. It's like a bromance, isn't it? It's beautiful.
Stop.
It's come a long way. We've come a long way.
I'm normal back, please. But it's super useful and it's great for patients. That's the reality.
You know, it's a person who said that from surprisingly, but says it really well is Bill Lombardi, actually, when he started doing more imaging, because the CTO type cases were always you finished, you crossed, and then you kind of just put the stents in. And he said exactly what you said, in the sense that, you know, you have to adopt that different state. But then once you do, honestly, that is what's going to keep this a durable result. And if you go back to this patient, they've already had a cabbage. And the right is going to fail potentially at some point because it's a vein, I think. And so this intervention that you do really has to be durable and long lasting.
Yeah, and actually, Ajay, there's a lot of hubris around this, particularly when you talk about mode of revascularization. And I can do this, I can do that. And it's not really a question about what any one person can do. It's about, from the patient perspective, the bypass has now failed. And we actually have to understand that these are revascularization journeys that these patients go on. And it's about optimizing each step of that journey, but not being naive about our individual importance in any one of that, but doing the best we can so that they get the most durable response.
So this is a 4.5x6 pop balloon.
Okay.
Right.
Okay.
You've taken your LED wire back at this point, Julian.
Yeah, I have, just because I don't want to get interaction. I don't want to get stent deformation. I'm going to pot early and do the ostium first, just because I don't want to get elongation as well.
4.5.6. It's almost like a ball, really.
Just take it around to probably there.
Let's just maybe you come to Spider for this, Joe. So really important here in terms of placement onto the carina. We don't want to be distorting the carinal dimension here and impinging on the LAD osteum. So we want that distal balloon marker. Yeah, pot well.
Yeah. A little bit.
I'm just going to engage my guide.
Steeper LEO there, Joe.
You okay? Right, 50 of fentanyl, please.
Okay, let's just take a short acquisition there.
That's all right.
I think that's actually pretty good. There's a tendency of ever to go slightly short, but we've got the imaging, so we can always be confident. I've made a measurement earlier. It was about 8 to 10 millimeters of length we had in the left main if we've stented where we think.
We've got some outflow track issue, I think.
Yeah, I was going to come to that because PA caudal, or the ARIA caudal view.
It looks too far, that balloon to me.
There's a circumferential edge dissection of the... Oh, maybe not.
Okay.
We'll see.
No, I think part of that might have been streaming, and we haven't we've got a bit of radial spasm. The guide is not wanting to go in, and so... and
also look at that projection in terms of the position. I mean, the ostium, I think it's very difficult to understand where that ostium projects. The measurement, again, on the imaging tells us it's 8 to 10 millimeters in from where we thought we were planning the stent.
Okay.
Right, let's do an OCT run now.
I think we had...
do you want to 4.0 into the CX first?
I would wire the...
And Ajay, I remember lots of endless conversations about prior imaging. Is that an outflow tract dissection? Is it in plaque? We don't need to, guess anymore, do we?
No. And the default was always to place another stent.
Yes, exactly.
It's so remarkable seeing this case because I have a patient I was just seeing yesterday in the outpatient clinic who had this exact same, as you said, James, revascularization journey, except the initial part of the journey was a stent that was just basically put in without adequate modification. And he's had brachytherapy. He's had multiple layers of stents. He's had atherectomy post-stent placement because he keeps coming back and restenosing with intractable angina. And at some point, this is like every 4-month occurrence. He's being considered for redo cabbage, et cetera. I think the idea that you can hopefully avoid that entire process for the patient by doing it right the first time the way you're doing it right now is really instructive.
Absolutely. A powerful story.
So, and just from a predictability point of view, what we're doing now, just taking a dual lumen, this is an enhancer RX, taking that into the circumflex, and then I'm going to wire my
And why do you
LED.
do this, Julian? What advantage is it?
I just don't want to... Yeah, so what you don't want to do is you want to predict where you're re-entering the LAD, and you don't want to go outside of our stent. Now, is that potentially going to happen? You can debate it, but I think it happens much more commonly than we think. And if you feel, what I don't want to do is end up just pushing and pushing harder and harder and distorting my Megatron stent. And
I think a dual lumen has a role, but with the imaging, I would tend to just now wire an image and check that I'm not abluminal.
We just move the screens.
But at the same time, I mean, there is a trade-off, and I think it's important to consider the trade-off, particularly for people who don't handle these devices all the time, is an awareness that the microcatheter in itself will alter.
You just want to take that back, Julian.
Tip force.
Yeah, I'm just getting it into position there, which I think is nice, and then obviously bring it back, get rid of that loop. I'll just come off camera.
Just center there
please.
for us.
Yeah, center there for us.
Well done, Joe.
Thanks. Then you see
go.
it just falls over.
Nice.
And I think, we can be confident that's within the left main. Where's it crossed? I'm not 100% sure, but that's where we're going to use imaging. And again, we'll trap this out.
Yeah, we're just getting to trap it.
But I'm confident that I haven't picked up any struts of that Megatron.
Well, it's impossible, isn't it? If your dual lumen is distal within the stent, it's impossible to go abluminal. That's kind of the point, isn't it?
Yeah, no, exactly.
What?
We could get it's imaging next, or is it kissing first?
Yep. Little image.
Because did I miss it, or have you post-deleted the circ stent?
Not yet, no. But if we're talking October protocol, then we want to know where this wire's crossed in terms of the strut location across the ostium. So that would be the reason for imaging first, and then moving forwards to a sequential high pressure kiss or sequential kiss. Certainly, maybe not high pressure in the LAD in the absence of a stent.
Yeah.
So let's take OCT. Let's see about deliverability.
How's the radiation dose for you?
1 gray.
Yeah, 1 gray.
Just got a warned. This is an old lab. This lab is 10 years old. It's an old. It was installed when we first moved into the Bristol Heart Institute. It's actually on its end of life, and it's going to be replaced this year. We've already got a new system coming in. We've got some of the new. This is actually a Siemens system. I don't think it makes a huge amount of difference because the technology from all providers has dramatically changed over the last year, and I think we'd expect to see. Yeah, guide extension, please. And we'll take a 2.5 balloon this time.
You haven't got any local badges, though, Julian, have you? You haven't got your personal badges.
Post-dilatations now?
We do in our other lab.
The Rayshaw.
Yeah.
Rayshaw, okay.
Yeah, no, that's in the newer labs. So it's coming online for us. I have to say though, with this egg nest and Adept starboard, you feel pretty boxed in and safe. It's an interesting feel to it. I haven't done it yesterday and today.
So yeah.
So let's have that 6-French Guidezilla back and the 2.5 balloon. Perfect.
The Rampart system is certainly.
We saw the pictures from yesterday. Yeah.
Certainly something we should all be looking at as well. Going for lead-free procedures if possible.
Yeah, or dramatic difference is light lead.
Guidezilla.
Instead of thinking we have to wear these chunky, heavy units with 10 kilograms worth of leads, etc., we can just go down to a much thinner.
Oh, there we go. Well done.
So an option would be to post-dilate into the CX.
Yeah, I don't know the downside to that, Julian. For me, you're going to have to do it, and actually, it's always slightly unsatisfying to do the imaging before you've done it, because then you know
what you've got to.
James, yeah, well, so the argument would be that that's not going to be sufficient for the bifurcation. So you're going to have to do a KISS. So you're going to image again to then check that your final results. So,
fair enough. But it does help with delivery and all those issues as well.
2.5 balloon, please.
Absolutely.
Tom, have you tried any saline OCT?
No, not fully. I have to confess I haven't. No.
Ajay,
I'm impressed by the 50-50.
Ajay, have you been trying saline OCT? Is that something?
Yeah, depending on the case, I think the 50-50 seems to work better, as you said. Full saline can work if it's less branches and that kind of thing. For this type of case, full saline with the size of the vessel lumens here would be a challenge.
Yeah. All right.
So let me just deliver that. Just go up gently there, please, Tom.
I'm just coming.
Oh, sorry.
That's all right.
And I'm just being a bit cautious.
You're still working this kind of iliocaudal view, Julian, aren't you? It's maybe not massively helpful.
Down left. Just... Okay, back to the ARIA caudal, please. 60.
And it's funny, actually, because we did a case with Rampart yesterday, and normally I'm very twitchy about any sort of highly angulated views. You want to get out of them almost before you're in them. because of the exposure to the staff. And definitely with these attenuation systems in place, you do feel a bit more secure about that.
Yeah.
Clearly, there's still the risk to the patient. You don't want to keep any dose too focused for too long.
Sorry.
But a lot of the backscatter issues are certainly resolved. So it's a check for the distal outflow primarily here.
Yeah, distal
Then a
outflow.
move to
Wire
kiss.
cross.
And then are you an advocate of a proximal pot after the kiss, Tom?
Yeah, well, it depends. I think we've seen, we've got eccentricity of left main already. We've got that calcium. I wouldn't be too worried about the idea of being left with an elliptical body to left main. So I think the important thing about if you are going to repot is that you don't go anywhere near the carina, because the last thing you want to do is undo the good work you've done in resiting the carina in the midsection.
Right, that.
Not tight.
Still a bit resistant, isn't it?
Yeah, I have distorted it, to be fair.
The catheter.
Your guide extension could follow it down a bit, Julian.
Yeah, what I'm going to do, because it's 6 French and we'll potentially get streaming outside, I brought it back actually.
No, but
into
put it
the
down
left
to
main.
deliver it and then take it back.
Oh yeah, no, I have, and I think that's a good position. So we'll see an outflow dissection there. Let's start this one again. Let's bleed out a fraction. Flush arterial. Thank you very much. Stop there. That's great. I'm going to just suck back here. I'm going to just check our pressure. We're good.
That's a bit low.
I'm just going to give a little check. We're getting good visualization. Not bad there. And I'm going to come on to that. We're ready to go. So. '54 pullback, a little wink.
I'm going to bring the OCT back up onto full screen.
Yeah, see it clearly.
See that calcium. See
Yeah,
the calcium
already,
removed. We're not in the stent. Importantly,
Okay, Joe injects.
injecting Joe. Great.
Good pictures, yep.
We've got enough there. What do we see at that distal edge?
Looks okay, I think.
It looks all right, actually,
Yeah.
doesn't it? You come in there, Sylvia.
Very characteristic look of the Megatron as well, eh?
Yeah, there is an area of lucency which you haven't imaged.
Yeah.
Further down. I'm just wondering if you.
Yeah, we may struggle to get the catheter down there with so. Let's skip that. We don't mind so much.
Might give it a go whilst you're actually doing that. I can use the OCT to help me do. No, I can't.
So we
I
have
don't
still
think you're
got.
distal enough, are you guys?
It's interesting. You've got a round ostium now.
Yeah. So we start from distal to proximal. So here we see a small side branch coming off.
There's
There's
a
a little
tear
bit
there.
of disruption. There's a disruption at midday.
12 o'clock.
Yeah,
You can see it tacked down so that
it's not. Yeah, so in terms of are we worried about that? It's less than 60 degrees. It's not extending into the media. I wouldn't necessarily be looking. I guess
think
the
it
issue
is
is
extending
that
into the media, isn't it?
lucency.
I think
I-
Tom, I think
There.
just go a bit further down, bit further down. I think it's.
That's
I think
plaque, but it's not media.
Right,
Again,
okay.
I see. In my practice, I would be willing to leave that alone.
Yeah.
But,
No, I would agree.
yeah.
But here it's gnarlier. I don't like that.
I'm not so
much.
sure, actually. I have to say, I'd be a bit twitchier about
And
that.
there,
I
look,
would.
there's more disruption here.
Yeah.
Just off that side branch. Let's just scroll right to the
I
bottom.
think if you can get the imaging out further, then I think.
25 balloon back, please.
I think you've got your information. I mean, there's obviously a judgment point here, but
Yeah.
I think the tear does extend into the media, and it does extend for longer than a couple of millimeters.
But we
And
see
it's
beautifully
visible
there.
angiographically as well, so whether that
Well, the
matters.
angiographic appearance is very distal to the stent. It's not actually on the stent edge, and that might drive you more towards having to cover it. Now, if we just turn the focus just for a moment, we'll look back at that dissection on the second run into the LAD cross. We've got a fantastic distal cross. Now, clearly, we've lost the 3D configuration here on the Ultreon, but if you focus as I frame by frame, there's the LAD wire there you see now coming into the left main lumen.
Yeah.
But it really couldn't be much more distal. We're cut right onto the carina. That next frame is carina there.
Yeah.
So I think we can be very confident that we can't do more to optimize placement of this provisional wire cross.
And the ostium looks very good, Tom, though, doesn't it? I mean, it even argues against whether you need to do much of a kiss there.
Perhaps, Tom, if you could just show us the longitudinal view with the OCT rather than the cartoon.
Yeah, of course I can. I'll open that up as well.
And see if you can then rotate round just to show us the wire cross point.
We're going to distal image, Tom. Do we want to do that? Are we going to take another bit of imaging distally?
You guys want to have a look at the edge, which I think is reasonable.
This guy doesn't. This guy is convinced.
But then, James, we don't actually know yet how far we want to land.
No, that's true.
And we've got nodules of calcium, we've got other disease there, so I think it is worthwhile.
Just rotate it backwards and forwards. Yeah.
If you see at 40 on the longitudinal, on the lower edge of that panel is where we've got the bifurcation. As I rotate it, you see there's the wire. Do you see that?
Very, very distal, yeah.
Just beyond 40, which is beautifully distal on the opening to the LAD. So you'd really hope then, I think, you want to kiss because you now can be confident that in kissing, you're going to clear those struts across the LAD ostium onto the roof of the LAD, really optimizing that. So
and just show us and you're right at the osteal segment now as well in the cross-sectional view, which has now gone from oval to round, I think.
Yes, it has, yeah.
So
up at the proximal edge.
Right in the very interesting as well.
We've got quite a lot of blood swell there, but yeah. Okay.
So I've just delivered the guide extension a little bit further down. Use a 2.5 balloon. We're past stent. I'm going to hopefully be able to get this catheter into the CX. I think there's a lot of hidden, as we always know, there's a lot of hidden tortuosity in this circumflex, and it's just a bit of a challenge. And I have caused some disruption to the tip of this catheter.
Giving it a good workout.
Right.
Struggling a bit there, Julian, is it?
Yeah, it's just I think it's tired, and there's I think there's just I don't know what it is in cases. The equipment does get fatigued. Maybe it's operator as well. We're backing out. I don't want to lose that wire. So we're compromising here a bit.
Yeah.
I think you probably should be pragmatic, because if you go back to that angiogram, you've got to. I understand that.
No, I know. We come round onto that horizontal, I think. We have to come round that bend and then stent 3.5 synergy or something into there. I think is very reasonable.
Do you want to image again with there?
Should we just do it? I think we're not much further. So
right. Now,
get your diagonal.
2.5 balloon back, please.
What's your wire in your diagonal?
Yeah, I know. I've seen it. Yeah.
3.015 non-compliant would be good.
Guide extension traps it a bit into that position, so it's just going to get. Going to leave it like that.
Okay,
it's reasonable.
So you're going to predilate and then implant a distal edge stent, and then do your sequential kissing.
Yep.
Yeah.
So what's this, a 3?
3.0 NC.
And we're coming onto the horizontal, aren't we?
Yeah.
Which is
It's
actually
pretty big. It looks 3.5. The vessel was definitely 4.
There's not many branches coming off, is it? Yeah.
Just remind us, place that angiogram again there, just so we can see what your target is like.
Oh, actually, so we've got the advantage of a roadmap, haven't we?
Yeah, we can't see that, of course.
It looks, yeah, our roadmap shows a nice horizontal plateau, whereas obviously with the catheter and everything down, it's changed the shape of that vessel completely.
Yeah.
Up there.
Just see where that small AV cert continuation comes off.
Just be careful, because I know. Sort of trapped in there a bit. Should be okay.
Maybe get your hemodynamics on screen as well. It'd be interesting to see whether you're getting much pressure damping with the. There we go. Not really is the answer.
Yeah, so that's a 15mm balloon, so it's going to be a 16. You probably just get away with a 16.
Come back a fraction, couldn't
a bit, and then we can just land it. 3, 5, 16 synergy. Bring it to the room. 3, 5 or 3.
3, 5, 16.
16 synergy. Yeah.
So Ajay, I'm conscious of the time here. I wonder if
we
should
that would be great.
Redo your talk and then come back once the guy's done a bit of preparatory work.
Thanks so much for having me. It's a real privilege to be here today. And I'm going to talk a little bit about how effective calcium modification can and will change revascularization indications and how we actually do revascularization by having new technologies at our disposal. Here are my conflicts related to institutional grant funding to Columbia and CRF from a variety of sources. I thought it'd be apropos to start off with a picture of Grunsig and this type A lesion that we don't really see anymore in the LAD that was treated successfully with a balloon angioplasty. That's really how our field began. And actually Grunsig's idea, which I only learned after the fact, was that these types of lesions could be treated early on. So we would never get to the state where we are currently with heavily calcified disease, multivessel disease, and beyond. The idea was this serial treatment of single vessel disease and multivessel disease would never emerge. And that would be a beautiful thing. Well, it turns out that clearly medical therapy works pretty well, and we don't really practice in that sort of rubric at all. And some of this has to do with clinical trials like the COURAGE trials and others that really showed that for many patients, optimizing their medical therapy, optimizing their lipids, et cetera, could lead to an arresting of disease of sorts, and outcomes that are very similar over the long term. So the question is, though, why do we still do PCI, and what are we seeing now in our current environment? Well, if you read the New York Times, and I'm from New York, so that's why I figured I'd show this curious headline that came out after the Orbital trial was presented that said that heart stents are useless for most stable patients, but they're still widely used, with this GIF on the right showing smiles and frowns and smiles and frowns back and forth in a cute way, because people are agreeing to an expensive procedure and putting themselves at risk for a placebo effect. So have we really come to this point? Well, clearly not. I think those of us that are in the cath lab nowadays, we don't see that lesion that Grunsig sort of looked at and maybe dreamed about. We see this. This is heavily calcified multivessel disease in a patient who's turned down for bypass surgery due to prior radiation. This is the type of thing that we see in the cath lab nowadays. And so clearly we're not, extinct or obsolete or anything like that. And we need to find ways to be able to treat these patients very effectively. That whole premise was behind this publication we put forth in 2016, where we talked about the entire CHIF initiative. And our goal here was to get away from executives who are having physicals and having inferior ischemia and having a type A lesion that was maybe borderline and getting stented, which we don't really think ought to happen. We were talking about what we were seeing at many referral centers, which was not that, but the type of case I just showed you, where patients were having an indication for revascularization. In other words, they had symptoms, they had low EFs, they had other things going on, and yet for whatever reason weren't actually getting it. And how could we equip ourselves to be able to take care of these patients effectively in the cath lab, to be able to do it safely and reproducibly over the long term? So when we sort of promulgated this, the idea was to shift away from this whole issue of overuse and to talk about this underserved population, to figure out that there are these patients out there, many of them are not even getting treated, period, and then to talk about how to treat them most effectively in the cath lab, through surgery and beyond, and actually to study it. And I think that's what the rubric for this talk is. So rule number one for success is to truly understand the disease you're treating. Don't just look at that New York Times GIF and assume that that's correct. Understand the disease process and what could be done, what should be done. And that's really often as challenging as performing the intervention itself. There is a simple principle here, and that is that diagnosing and treating severe coronary artery disease is clinically important. And it's not just for symptoms, it's also for prognosis as well. We sort of had this schematic when we talked about this CHIP population, or complex higher risk patients who were indicated for revascularization. And square in the middle of this is calcium, because we know that that's a downstream thing that happens when people have have chronic disease, chronic CAD for a long time. It often happens when you're confronted with it because patients have had surgery or they turned down for surgery, et cetera. And calcium is a key component of what we've dealt with here. Now, talking about undertreatment, though, many people will say, well, what do you mean by undertreatment? We can treat things in the cath lab nowadays. And so it's important to look at a couple streams of data. This is an analysis of patients who were seen in the US-based registry with left main or three vessel disease and a presentation of a non-STEMI. And this graph identifies hospitals' proportion of treatment of these patients who have two type 1 indications for revascularization, non-STEMI and left main three vessel disease. And yet, some of these hospitals treat these patients medically 30% of the time or more. Now, why is that? That may be because the patient has too many comorbidities, but it also may be because people are seeing things on the angiogram that they're scared to be able to treat safely. And perhaps with the adjunct of newer tools and devices and techniques and teaching, those patients could actually be effectively treated and helped in that regard. We also looked at other data looking at patients that had heart failure diagnoses, how often they're even worked up for ischemic heart disease, and soberingly, that's only seen in 30% of cases, even after the first time presentation of heart failure, not even looking for coronary artery disease as an etiology for it. We know that if you're going to find it, it's often multivessel, it's often more severe and complex, but yet if you don't look for it, you're not going to necessarily find it. And beyond the clinical syndromes, what about when we talk to the patients ourselves? Are we actually asking patients the right questions to determine if they're limited by their coronary artery disease? This is a really interesting study from Mid-America Heart Institute and Suzanne Arnold, where she actually queried the patients themselves by asking them to fill out the Seattle Angina questionnaire. And then she asked the doctors taking care of their patients, does your patient have angina? And it turns out that these are individual physicians on the chart. Some physicians here under-recognize their patient's angina 80% of the time. In other words, they may have said, are you having chest pain? The patient says, no. And that was it, except when you ask the patient, can they walk to their end of their driveway? Can they walk their dog? Can they do things they want to do? The patient would say, actually, I can't do those things, but no, I don't have chest pain. And so especially as disease gets more severe, diffuse, chronic, calcified, you see more of these types of presentations rather than your typical chest pain angina syndrome. Now, we do know that revascularization as a whole can improve quality of life, and in all complex lesion subsets, such as those from the Freedom trial, those from the Excel trial and beyond, we get vast improvements in quality of life with revascularization, and it happens immediately after the procedure is done. And the way I would sort of summarize this is our patients with real symptoms after revascularization will send us notes like this, where they thank us for all of our help. It's a great feeling to be angina-free. And by the way, the byline is they're on less medications or tablets because their symptoms are controlled, so they don't need them. So that's the part about symptoms. Now, what about prognosis? Also, it's important to consider that we do affect prognosis when we have severe and complex coronary artery disease. It is not just about symptoms as a whole. This is from the ACC/AHA guidelines that show as we get more and more complex in terms of the diffuseness of disease and how we have more multivessel and proximal disease, the survival rate at 5 years starts, approaching 60%. So if you have a 60-year-old gentleman or a 60-year-old woman, you're basically talking about a 4 in 10 chance they're not going to be around to see their 65th birthday. And that's a problem, and we need to be able to deal with this. It turns out that revascularization in severe and complex anatomy can actually improve outcomes. And this is just an associative study that we published in JAHA this past year. Kevin Bainey was the first author, showing that if these patients are medically managed, they happen to have worse outcomes than those that are revascularized. Of course, this is subject to selection bias, but it's still important that complex disease can affect outcomes. We know that disease like left main, there are randomized trials showing surgery superior to medical therapy. We know the same has been shown in ischemic cardiomyopathy with surgery, despite the upfront risk of it in the STITCH trial and the STITCH's extension study. There is a mortality benefit to revascularization in these patients. And even in the ischemia trial, if you look at the original endpoint, which was cardiovascular death or myocardial infarction, despite the fact that 1 year, because of the upfront risk of the procedure, there is a favoring in terms of the conservative strategy, at 3 years and at 5 years, and this is a Bayesian analysis in the New England Journal of Medicine supplement, you start seeing a difference favoring the invasive strategy, just capping the patient to be able to determine what their anatomy is and then potentially revascularize them. This is remarkable because in the ischemia trial, remember, of the ones that got capped, only 80% of them ended up getting revascularized. So this is still with a 20% less effect, and the fact that in the conservative arm, almost a quarter of patients did get revascularized later as well. We know that from the ischemia trial, we can reduce myocardial infarction that occurs spontaneously outside the PCI by doing PCI. And that difference in reduction is actually similar with CABG and with PCI within the study. So we are reducing late events by doing it. Of course, we're offsetting those late events by our upfront procedural events, which is why we need to do these procedures more safely. So how do we do that? Well, how can we be properly trained to do this? We need the right training, we need the right tools, and these tools together applied in the right way for the right patient can effectively get better outcomes. We elucidated some of this in our CHIP paper, and I've modified this slide to talk a little bit more in calcium disease, not just about things like atherectomy and balloons that we've had for a long time, but IVL, imaging, and how critical those things are to modify the treatment approach. What's very important, though, is if you don't have the right tools, you will undertreat. And this is something that we see. If the patient's symptoms are real, or the risk of leaving that residual ischemic territory is greater, then why are patients so often being denied treatment? Because the interventionalists are not trained or comfortable enough with advanced PCI techniques to treat me. And that's one of the reasons why, if you have technologies that are more easily accessible, it sort of changes this calculus entirely, because you may be able to now revascularize safer things that you wouldn't be willing to do before. So in the past, if you had that tight osteal circ like we saw in the live case, and you were worried about a perforation, you might not proceed. And that's okay in some respects, because you're trying to avoid a complication and you don't want to hurt the patient. But what if you had tools or techniques that you could do that more safely? Then you might be able to offer the revascularization to those patients, and that would help. This is especially amplified when we think about low volume PCI in the United States. This is also echoed in other parts of the world too, fortunately not so much in the UK, but in the US, at least 44% of operators perform less than one PCI a week. So it becomes hard to use technologies and techniques that are not so easy to use, because people are just less familiar with them, and that can cause problems. And we know that as we get more complex, whether it's through left main disease, whether it's through CTO PCI, volume and outcomes really have an important relationship, especially with these advanced techniques. And so the question is that are there technologies and tools out there that are more reproducible, that allow less experienced operators to use them? We need to know that our outcomes at an individual site are variable based upon the operators. And this is a famous slide from the Syntax trial, basically showing the outcomes at every individual site. And there's certain sites that did really, really poorly with stenting. The 50% or more rate of MACE and no adverse outcomes with CABG. At still reasonable numbers of patients. Over here on the right, this patient did terrible with bypass surgery and did pretty well with PCI, despite being having treated with the Taxa stent. So you need to know your own individual operators. You need to know your case selection. You need to know the techniques and tools you have at your disposal. And that's one way we can titrate according to our institution. If we just assume everybody has this treatment effect shown by this line, that's not going to be reflective of real clinical practice. And so this is just an illustrative case. This is a patient who basically had stents that were deployed, conventional operator, outside institution, in the proximate LED. And unfortunately, the stents were underexpanded because imaging was not used. It wasn't adequately pre-dilated. The patient came back and then was referred to a specialty center where rotational atherectomy with stent ablation was done with further PTCA, and still unable to expand the stent. And the patient came to us with continued angina. This is the Prox LED stent, and I don't know if you can appreciate, you'll see with the balloon inflations how dramatically underexpanded this residual stent is even after atherectomy. IVUS wouldn't cross, 2.0 balloon wouldn't cross, so finally a 1.25 balloon crossed, and these are the balloon inflations, just showing how dramatically this is underexpanded here. Now, you could argue that had this been treated right the first time, you'd never be in this situation. That's one argument. The second argument is, what do you do at this point? What do you do? You've done rotational atherectomy of the stent. You're trying to dilate with NC balloons, and many people would send this patient for bypass surgery at this point, which is fine to do. But what if we had other tools and techniques? And the question is this case more broadly generalizable? And I would say it is. We see a lot of cases like this where calcium is not treated in the right way. Even in cases where you're not supposed to have calcium, for instance, in DES trials where you're supposed to exclude patients with moderate to severe calcification, we showed that you could see it in up to 30% of cases on the angiogram. And as you get more complex to studies like the Syntax trial, you see that calcium severity is seen in almost half the cases. So you need to have tools and techniques to treat it. Now, we know that calcium in the artery can result in decreased ability to deliver stents, but also there's increased rates of complications and the inability to expand stents as well. And that's shown nicely in the slide. As the arc of calcium gets greater, you get more and more under expansion. And I know this has been covered in multiple other talks, so I don't want to go into it in detail. I will say, though, that the rate of adverse events following treatment of calcified lesions is among the highest that we typically see. And it's not just short-term events, it's longer-term events, and even events like stent thrombosis. There are many tools out there, and fortunately now we have more and more at our disposal, and they're getting slicker and slicker, and that's good news for patients because having effective tools will allow us to revascularize patients more effectively. We also know that for certain tools, and this is the good example from Milan of rotational atherectomy, that the effect of not doing it up front, not addressing the calcium head on, such as known as roto-regret, is associated with not only much longer procedure times and contrast, but more balloons used and also potentially more complications. And so identification and treatment upfront is really the way to go. We see that in certain populations in the US, this is our VA experience where we see over time there's an increasing evidence of calcification, atherectomy being used in up to 18% of single vessel PCI cases. But despite that, at those centers, in the US at least overall, the rates of atherectomy still remain quite low, even though they're rising. And notably, among hospitals performing PCI, a third perform no atherectomy at all. Which leads me to question, how are those patients being treated? Are all those patients being referred, or are many of them just being treated medically, or many of them being treated surgically? So the fundamentals, as I conclude this talk, of this CHIP mindset is that the clinical indications for the case are static. The patient has symptoms, and if the symptoms are severe, just because the lesion is harder to treat, literally harder to treat in the case of calcification, does that change what we want to offer the patient? Of course, if the risk is higher, then it might. But the idea here is how can we get the patients the treatments they need, and can we modify this based upon techniques and tools at our disposal? I would say yes, we can. And I would also say that coronary revascularization is certainly alive and well. It's certainly not dead. And it's been appropriately redirected to higher risk patients and lesion subsets. So it's important if the patient has minimal symptoms and has responded to medical therapy that you don't have to treat everything. But when they have real symptoms or real disease, real prognostically important disease, those are the people who we really need to know how to treat. And we're seeing more and more of them as the population ages, as we have more comorbidities. The surgeons don't often want to do these cases, and as we see them later in their presentation. We know that calcified lesions are among the highest risk lesions that we treat, and they influence the revascularization strategy offered to the patient, either favoring medical therapy or favoring CABG. That's because we don't want to hurt patients, and it can cause longer term outcomes that are bad and also short-term procedural risk. So in essence, the ability to modify calcium reproducibly, safely, algorithmically, as shown in the live case, is going to affect how we treat our patients, what we can offer them in terms of choices. And as data keeps getting updated in the field, we have a lot to look forward to. So thanks so much for that. Happy to have a discussion and take questions.
Ajay, that was great. That's what I refer to as a proper first order talk, not a talk about bits and pieces, but why we do things. And that's where the value lies. And value is actually what I come back to in this, that the value of what we do to patients or what we can offer to patients is really where we should be having the discussion. It's not just about risk, as you say. It's not just about benefit. It's about the value to them as well. So I don't think you could have phrased it better in that eloquent walkthrough. So how has your thoughts when you have that discussion with patients changed since introduction of this concept? Presumably you're having conversations with a totally different subgroup of patients now.
Yeah, I think first we get referrals for patients that have had disease that was previously, thought to be untreatable or more difficult to treat. I also think that the issue, for instance, of the underexpanded stent, obviously it's an off-label type of situation at present, but depending on whatever technology you use, it's off-label. These have been problematic patients. And when you're at a referral center like ours and yours and everyone's that we see, you see these patients. And even if you're not at a referral center, there are doctors who have these patients who they really want to help, but they can't. And so my feeling is that having more tools at our disposal to be able to think about it, and that's not to say these tools are panaceas either, but at least to think about options and be able to consider them even our surgeons are excited. And as you know, we've said many times that we work so closely with the surgeons back and forth referring each other cases that we're all excited when there are new advances in the field as a whole.
I totally agree, Ajay, and I think actually when you contextualize things in terms of patient value, you can really make a proper discussion about cost and so on. Cost in isolation really doesn't tell us that much. And I think with that in mind, again, Jonathan and I would like to thank you for a fantastic presentation. It's contextualized perfectly within the context of this case. So we're going to go back to Bristol and see how they got on.
So welcome back. Should we just show you the steps that we've done, and then we'll show you some imaging?
Yes, please.
We have crossed the left main into LAD. This is a 2.5 semi-compliant balloon. Next step. This is us just play that one, just delivering a drug-eluting balloon. So this is a 3.0 drug-eluting balloon, 3.0 drug-eluting, and a 4.0 non-compliant balloon. I'll put the 4.0 non-compliant in first, just in case we needed to trap the 3.0 deb across. They are relatively bulky. Kissing here. So we went first up on the deb for 45 seconds. So NC first, then the deb, and then we did a kissing. And then we just...
Kissing with the deb, yeah.
Fresh. So yeah, so that's the 3.0 deb and a 4.0 non-compliant balloon. And then what we've done, we've taken a 4.5 just to the very proximal bit of the left main. So next shot, please. 4.5 short balloon, just making sure that we've optimized that. And then we've taken the guide extension back down on a 2.5 balloon, keep going forwards. Guide extension is delivered quite far, and OCT, next one please, is now being delivered distal. So that's where we do our run from. This is our OCT run. And actually, that was a power injector with 50-50 saline. We didn't get a great result. We then went to 100% contrast. Next shot, please.
It's because your vessel keeps looking bigger and bigger and better and better. It's a phenomenal result.
And we're hanging out, and there is, issues with the radial and my guide. The patient doesn't like it when I manipulate it. So a few factors, but, we're getting, as you see, a big, big vessel here. Tom, do you want to show OCT and tell me whether I need to do more?
So it's interesting. So we've just taken this run. I've just been making some measurements. I'm having to get around this Ultron software, so bear with me. If we focus at the moment, I'll enlarge up this longitudinal view here. So here I've outlined. Now, interestingly, the automated stent detection suggests that there's stents. So if you see the hashing in the lumen profile, the lower panel, it's suggesting with that hashing that we're in stent here. Now, the difficulty we have, and if you remember that discussion we had around the distal vessel, distal to the initial stent we placed, we've got all this nodular calcium. So you see that nodule at 12 o'clock, we pan down, it rotates around to 8, 9 o'clock. We come a bit further, we've actually then there's some artifact here as well, but we've got additional nodularity in that vessel. And so the contour of this vessel is really difficult to actually make out, but we just see this very complex calcific disease, multiple protruding nodules. If we just focus on the stent segment itself, if we look at the MSA parameters of the circ segment of the stent, it's divided into two. Right on the distal edge, we're at 4.7, so above that 4.5 of the consensus that we're looking for optimization. And really gratifying, we may not have time, but to show the comparison of before we did the KISS to after, we've taken the MSA in that very proximal ostial segment of the circ from 7 to 8.4. If we then focus on the left main, you can see already on the little strip below the longitudinal, the yellow markers, which are telling us we've got malapposition. So if I just scroll into that, we see very clearly the stent significantly undersized, a very large vessel.
That's dramatic, Tom, eh?
And angiographically, there's just no way you'd see that. So we make a measurement here of the size of the left main. Again, that we talked about previously, the eccentricity of this area of the left main. We see that coming up to 4.7, 4.8. We've taken back a 4.5 balloon now to hopefully re-optimize that. There is this little dissection. Again, we knew landing into that nodule of calcium, we were in danger of having some disruption. We have got disruption. I don't think we're going to be tacking that back with another stent. I'd like to think that'll be stable.
So if we just now focus on
it is, if we focus, it does extend back into the body, into the left main pre-stent. If I just demarcate the true left main segment, we see now gratifyingly we've got an MSA up to 13, 14. So if we could extrapolate to that noble data, that suggests we're giving this patient the best possible chance of avoiding future events. But we see again, this is not a circular vessel. We are dealing with really, really high-grade disease.
Yeah, I mean, it's really complex disease, but I think actually we all looked at the angiogram and we thought, great, you're done. And that couldn't be more dramatic, that proximal edge of that stent. So that needs to be sorted.
4, 5, 6.
Listen, I think in the interest of time, guys, we're going to thank you for your fantastic contribution. And it's lovely to see the new dream team in action. This bromance really has brought a real sort of je ne sais quoi to the masterclass, and I can think of no better way to end with that feeling of love in the air. So thank you both, and thank you to the Bristol team for such a fantastic demonstration.
Brilliant. Well, thank you very much. We've enjoyed it here. Thanks very much to the team.
Fantastic result. Well done to all of you.
And a big thanks to Ajay for his fantastic contribution as well. Now, over the course of this series, we've had hundreds of questions from the audience. And while we tried to answer as many as we could in the live chat, there were some that came up often, or those that were particularly pertinent, which we decided to answer directly. So with that in mind, we've invited a few guests on to ask those questions. Starting with Alfonso Gerardo Ramon. Alfonso, what was your question?
So my question I would like to ask to the experts is if they think that rotatripsy should be the therapy of choice in critical and deeply calcified stenosis.
So great question, Alfonso. So I think you're asking about the combination of rotational atherectomy and IVL, and really wanting to understand about the indications for where we would be using the two modalities together.
Yeah.
So I think we've just seen in this live case done from Bristol that the heterogeneity of calcium distribution, particularly in the left main, that we've seen concentric calcification, eccentric calcification, and nodular calcification, all in the same lesion. And I think the fact that we see this heterogeneity means that we need more than one modality to modify it. And I think the logical sequence, if you're trying a pragmatic approach to calcium modification, is that following imaging, once you understand the distribution, if IVL will cross, then use IVL first. But in a situation that we've just seen, where there is clearly nodular calcification, atherectomy has to be the modality of choice. And that it's the superficial modification that is done first, but that doesn't preclude you then using IVL for the deep calcium modification. So I think where there is this range of distributions of calcium, and especially when there is deep wall calcium, IVL is going to be part of the treatment strategy. And I think in Europe, where there's relatively little experience with orbital atherectomy, I think that ideal combination is going to be, as you suggest, rotatripsy or rotashock, or whatever name we give to it. But combination therapies with some form of atherectomy and with IVL, I think we're going to see them done increasingly frequently, especially in these very complex cases that we're now being referred, especially in left main stem disease. So rotatripsy, absolutely, I think is the combination therapy of choice.
And Alfonso, we actually did a deep dive of this in class 7, and I think it'd be great to refer to that. But what is your perspective and your experience within this field?
No, I absolutely agree with Jonathan. I think that when you have deeply calcified lesions, probably shockwave is the best way to achieve a good expansion and a position of your stent. But the problem is to deliver the shockwave balloon to the lesion if you have a critical stenosis. So you have two options: or waste time and efforts with growing sized balloons, or make a channel with rotational atherectomy or even laser, and let shockwave balloon to get there. So we have some experience with this technique, and the only concern is the economic point of view. But even with this question, I think it's more expensive to implant badly an stent than to use the rotatripsy. So I think I agree with Jonathan.
Yeah, I mean, that's an excellent point, Alfonso, that there's nothing more expensive than a badly done procedure. So we'd really like to thank you for your support and bringing this question, which I think is extremely relevant for all our viewers. So big thanks for your time, Alfonso. Hope we see you soon.
Thank you.
Thanks,
Bye.
Alfonso.
Hello.
Hi there, Professor Werner. How are you?
Good. How are you?
Very good, thank you. Very grateful to you for taking your time to share your expertise today. So have you got a question you'd like us to address?
Yes, I think it would be interesting to know what your ideas are on how to adapt the IVL technology to the coronary space. I think that would be really interesting.
Yeah, I mean, it's a great question because, of course, people know about IVL in terms of its extracorporeal lithotripsy, which is what we use to fracture renal calculi. And we think, well, renal calculi, that looks a bit horrific. How do we avoid such an explosive environment within the coronary space? And you can think of the adaptations of lithotripsy within the coronary space in three major ways. The first is the energy flux density and the waveform. So the waveform applied from intracorporeal lithotripsy or intravascular lithotripsy is significantly reduced compared to extracorporeal. So it's a much smaller wave, and the negative part of the wave, again, is much smaller. So you don't get cavitation effects. And cavitation effects is actually very harmful within the vascular space. Of course, you don't want rupture. You just want disruption, that dissipation. So that's the first thing to say. The second thing to say is that the pulses have been incorporated within a balloon. And whilst that seems obvious to us as interventionists, of course it's in a balloon. Everything's in a balloon. Actually, what's critical there is that the balloon stabilizes the energy waveform. So it's a platform, it's an anchor, if you like. And the fluid within the balloon acts as a way of ensuring that the shock wave isn't dissipated within a gaseous structure. Because actually that interface between gaseous structure and within a fluid-filled structure is actually where you get cavitation. So for example, in extracorporeal lithotripsy, you want to stay away from the bowel because you can actually cause bowel rupture that way. So the fluid within the balloon ensures that, first of all, the balloon is fixed in place and there is a smooth transition of the shock wave between the fluid and the vessel wall, etc. And then the final thing to say is the arrangement with the emitter algorithms. So within a coronary balloon, there are two major emitters. So there's a waveform around both, and there's a summation wave in the middle. That enables the effect, the field effect, to be broader, if you like. And of course, that's adapted peripherally, where there's three emitters, and they have a different kind of transmitter to each. But within the coronary, the main problem we always have is this: how do you miniaturize things? How do you keep things small enough that you can actually get the balloon to deliver? And we've heard a lot of practical questions about actually, well, it's quite difficult to deliver compared to a normal balloon. Well, that's because it's got these two emitters within it. And that obviously they take up a certain amount of bulk, which you can't sacrifice. So we did a very deep dive to this, which will refer consequent on your great question in class 4, in which we explained the basic principles behind shock waves and how it's adapted for the vascular space. Because as practicing interventionists, what we want to know is not just is it safe, but is it effective as well? So that combination of safety and efficacy is absolutely critical for it to work. So fantastic questions. Any thoughts yourself on your experience with lithotripsy and your perspective of where it's best applied?
Yes, I think so. Very, very interesting information. And I think in clinical practice, you see that it's really a very safe and low complication procedure. And I think this is something what you just explained, but this is also what transfers into clinics, so that we really have very low complication rate with the shockwave balloon. And the other thing is that despite the two emitters within the balloon, you just mentioned that it's a little bit more difficult to advance the balloon. I think it's really fantastic how it works and how you can bring it to your target lesion, even that the balloon is a little bit thicker. But compared, for example, to scoring balloons, I think it's much easier to bring the balloon to your target lesion.
Nikos, that's a great question. We're very grateful to you for bringing that to the audience today. Very much like to thank you for bringing your expertise and your enthusiasm to the session, and hopefully we'll see you soon. Thanks, Nikos.
Thank you.
Nikos. Good to see you.
Take care.
Hi, James.
Hey, Stefan. There you are. So listen, great welcome you to this class. I know you've been an enthusiastic supporter. So I've got a question for you before you ask Jonathan your question. Tell us what you thought of the series so far and what you've learned and how you've applied that to your clinical practice.
Well, you guys are just making me think every day. You know, you're just like back in my mind when I'm doing work with my hands. And I've started with the shockwave IVL when it came, I think it's 4 years now, rather early for Austria. And I did this in a very small hospital on the other side of town. And they even invited me to the university because they saw, okay, this guy likes to do calcified lesions and is enthusiastic about new methods. And so the connection with you, be it digitally or be it in person, just affects my daily life. Whenever I do simple things, I ask myself two questions all the time. What would James do now? What would he ask? What would he criticize? Would I be able to
Almost everything, Stefan. Almost everything.
But Professor, you know, you are important.
You're too kind. You're too kind, Stefan.
How can you say
You're
that?
too kind. I wasn't actually trying to prompt you to say that, honestly.
Thank you so much. No, it's a pleasure. You know, I'm not the youngest guy, and it's just a continuous pleasure to be in touch with people who like to push forward the limits.
Well, it's a pleasure to have you. I know you've got a question that Jonathan's going to address, so thank you for your enthusiasm and your support.
You're welcome.
So, Stefan, I'm waiting for your question. What?
Jonathan, I have an everyday question, actually. With IVL, we have more and more difficult lesions and incompliant vessels we are facing. And we often use guideliners or guide extensions, I would say, to get our IVL balloon down. And then we have something like a quandary. We want to get this down. It is expensive. We want to apply all the pulses possible in the right spots. And then this takes some time. It's not a lot of time, but it does take time. And I see myself, even if the pressure curve is going down, I see that I'm reluctant to pull the device back out again once I've started using it. And I wanted to ask you guys for all kinds of tips and tricks, how to keep ischemia low, how to not affect pressure, and still be able to take advantage of all the pulses possible.
Yeah, I think that's a fantastic question. And I think we've kind of worked out those practicalities, and I think you've been an extremely important part of that because you've been thinking about this from the outset. My approach is that if I think the lesion is going to be crossable with a balloon, but there may be some difficulty in crossing with an IVL catheter initially, that I will go up front with a guideliner, and I will take the guideliner down to the lesion, to the distal part of the lesion that I'm going to treat, and to use a 2 millimeter semi-compliant balloon to deliver the guideliner. So we'll do that much more routinely if I've got a long segment of vessel to treat and I want to deliver the shocks all the way from the distal part of the lesion back to the proximal segment. So that becomes a more routine part of the case. I think that with the balloon inflation, when we were doing the trials with the Disrupt CAD1, CAD2, CAD3, that we were going through this prescribed protocol, 4 atmospheres, apply the 10 pulses, go to 6 atmospheres, then wait a little while, take the balloon down. And for impatient people, I'm not saying that you're impatient, but I think most interventionists are quite impatient. And I'm not sure that the higher, the 2 atmospheres extra really makes much difference. So my strategy is to go up to 4 atmospheres now, give the shocks, take the balloon down immediately, and then I'm waiting for it to reactivate, and just before it reactivates, I'm inflating again and then pressing again. And then I will do that sequentially coming back. Now, in the situations where there is you're concerned about ischemia, then it is possible to deliver the shocks in shorter pulses. But I've actually found that really rarely to be, I don't think that's required. So I think the short answer is use a guide liner up front, deliver to the distal part of the lesion, and then work your way backwards, not to do the 6 atmosphere inflations, and then to do it as quickly as possible, deliver all the shocks across the whole length of the lesion. And I think that way you avoid ischemia and you do it very efficiently and quickly.
And if you're worried about delivery, which the scenario we're talking about, and ischemia, one thing you can do, because ischemia, obviously the impact is territory dependent, how much territory is affected, and length of inflation, sort of as a combination of the two, really. So the more distal you are, the lower the risk of ischemia. You still get ischemia, smaller territory. So if you've got a problem with delivery and you're concerned about ischemia, I think what you can do is use a 7 French guide, but a 6 French guide extension. Mm-hmm. And you can retract the guide extension in between inflations. So you do your inflations, you retract your guide extension, and you leave your guide extension back in the guide. And that way, as Jonathan says, you go from distal to proximal and you minimize the degree of ischemia at the same time. Probably the area that we're most concerned about is the left main, because it's a proximal territory, it's 2/3 of the heart. Ischemia is most likely to have the most negative impact. And I know Jonathan and I have certainly done combination cases in which, if we're very concerned that the LV is an issue or the right coronary artery is occluded, we have used LV support on occasion. And sometimes I think it's one of these pre-procedural planning steps that you have to make. If I'm going to have to do a lot of proximal balloon inflation and this patient is potentially likely to go in an ischemic spiral, then LV support is, very occasionally, but still not that infrequently required.
If I just give you a little anecdote from a memorable case that I did with James, one of the first cases, an impeller shockwave case done at St. George's, is that this really was a very precarious situation, somebody with very poor left ventricular function, with very severely calcified left main disease. And sometimes in that scenario, I'm sure you'll be familiar that with when you're using an impeller, is that the patient will become non-pulsatile. And this particular patient, whilst we were doing the left main calcium modification with IVL, became non-pulsatile. And James, I think a few weeks before, had come up with this idea of shock topics. And, we're all familiar with shock topics. And thinking that this was a bad thing. And the balloon was up in the left main. The pressure was flat. So flat pressure of 60 or 70. And he pressed the button, and then it started, and it went back to pulsatile pressure. So that for me was the proof that shock topics can be therapeutic.
Mechanical coupling as well as electric coupling.
In the context of mechanical support in combination with shockwave. But I think your point is very well made that, yes, we've got a tool here which is very effective at delivering therapy. And I think there are steps that we can already take to moderate the way we're delivering this therapy and to reduce ischemia.
I think this is quite helpful, what you just told me. And I learned also something I want just to confirm now. So can I rely on the device in a way that it will not let me apply pulses when the system is still, let's say, too hot and may hurt the balloon. Is this also part of the algorithm that makes, does it take some time to recover for the system, or would it be possible to apply more pulses in shorter time?
Yeah, I mean, that, as you correctly say, that was due to heat dissipation, and it's actually, the studies have been done with respect to how much temperature it rises. They're kind of important regulatory studies, and that's one of the reasons, of course, we fill the balloon with fluid as well, and we space the transmitters and we limit the pulses. They're all down to minimize heat dissipation. But in those studies, almost no heat is generated, actually, very, very low amounts of heat. And it may well be that further iterations of the balloon have got more pulses, and you're able to deliver more pulses before you stop. And there was also that theoretical concern about a 10-second inflation of a balloon. And we find clinically that's normally irrelevant, Jonathan, isn't it?
No, it is. But remember, in the peripheral, with the peripheral balloons, they're longer balloons with more emitters. They give you, cycles of 30, and up to 300 pulses. So perhaps we might see with the new generation of shockwave catheters for the coronary that maybe we'll have perhaps more shocks, perhaps there may be some higher energy. But I think the engineers, who've done a fantastic job so far, are looking at all of these new developments.
Yeah, and actually, we can also refer you back, Stefan, to class 4, where we looked at the temperature deviation. And I think it was never any more than a degree during the pulses. So, but if you're designing a device, what you don't want to do is go in and start causing problems. You want to be, of course, efficacious, but you don't want to cause problems. So, excuse me, and I think actually they've done a great job, but equally we have to commend your engagement and engagement with all the physicians in this class. And, these aren't problems we're solving in isolation. These are problems we're solving together. So a big thanks for your commitment and your enthusiasm, Stefan.
If I could just say, I think, the use in the real world, and you've been a really extensive user, I think the real-world experience mirrors what we've seen in the trials, is that there is overwhelmingly a strong message about safety here, that the safety of this device is really, has been very clearly established, even in the very complex patients that we're now treating. So I think highly effective and extremely safe.
I can fully agree with that, because I really didn't run into any big trouble with shockwave so far.
No.
It was more the greediness that I didn't want to take the device out and use a new one, because we have some funding restrictions also. And I take from that also that I think you are also using it forward motion also, like if you cannot get it in, do you start proximal and push it forward?
I've been doing some inchworm, so taking a guide liner down with a shockwave, working your way down and then working your way back up again. Yeah. And
something common which I often use when I put a stent in a delicate position far distally, that I put down the stent and I take back the guide extension and then continue with my application of the stent. I can do the same with the IVL balloon. I can get make some more space, because the guide extension by itself does induce ischemia. And if I take that out, there is more space for the blood.
Exactly.
Absolutely.
Listen, again, Stefan, big thanks for your time today. Hopefully we'll see you perhaps in Austria again soon, eh?
I'm so much looking forward to meeting you in person again. Thank you so much.
All right, Stefan,
Thanks,
take care. Great to see you again.
Great to see you.
Thank you.
See you.
Bye.
Stefan, bye.
Bye.
I would like to ask to Professor Spratt and Dr. Jonathan Hill one question. How important is the use, your opinion, of imaging for the strategy in the choice between IVL or atherectomy, orbital or rotational? And second question is, what kind of imaging for you? IVUS or OCT in long, severe coronary calcified lesions?
Thank you, Fabrizio. That's a great question, and really is something that's very close to my heart. And we've gone into this in really quite extensive detail in class 3. The short answer to your first question about imaging is I think it is of absolute fundamental importance, and I think it is central to everything we're doing with the management of these complex patients. So I'm an advocate for near universal intravascular imaging where that's possible. So if it's possible, it should be done. And it should form the starting point of every algorithm that we use to decide on the optimal mode of calcium modification. Now, the algorithms, there are multiple algorithms now appearing around the world, and certainly IVL has ignited this sort of collective thinking amongst interventional cardiologists. But the essential measurements that you're making with intravascular imaging are related to the 3 aspects of calcium distribution: the concentricity and the distribution of calcium around the vessel, and the thickness of that calcium, and then the extent of the calcification along the length of the vessel. Now, of primary importance to me is the degree of concentricity, deciding on whether it is concentric or eccentric. But the third most important aspect of calcium distribution is also being able to detect nodularity, and that nodularity is actually an indication for an atherectomy device. So your question about IVUS or OCT, I'm clearly a strong advocate of OCT. And the reason for that is because of the spatial resolution, and in particular, the additional information that OCT gives you over and above intravascular ultrasound. And in particular, when we're looking at the depth of calcium. And really, if you can understand the concentricity or eccentricity and the depth of calcium, that is the essential information that you need to make a decision. So, short answer for the first question, fundamental importance, and secondly, OCT is my modality of choice.
In fact, Jonathan, the short answer was yes and OCT, wasn't it? Fabrizio, what's your perspective on it? Do you think images is important? And if so, which type?
For me, in this setting, the images view is fundamental, is mandatory. I use generally in the complex PCI sect in the IVUS. It's very immediately, and we are an easy view. It's in general. But however, when we are in the context of long and calcified angiographic lesions, I prefer to use the OCT, as the IVUS view is injured by the presence of the shadow in the case of high calcific burden, while OCT allow me to better see both superficial and intramural calcium of the wall, and also allow me to evaluate the correct sizing of the total vessel in this concept. So I'm completely agree with you.
That's a great answer, Fabrizio. Listen, thank you so much for bringing this question and your expertise and your support for the class, and we're very grateful for your time as well. Thank you so much. Hopefully we'll get a chance to see you soon, Fabrizio.
Thank you so much.
Thanks, Fabrizio. Yes, that's about all we have time for today, and indeed this series. All the classes and additional learning resources are available on the Shockwave Hub on Wonder Medical.
So a big thanks to Optima Education, and especially to James Spratt, who has done a really phenomenal job in putting this masterclass series together. So I think the last word should go to James.
Yeah, thank you, Jonathan. You're too kind. It's a team-based approach, but we're very grateful that you joined us, and we'll see you sometime in the future. Goodbye.
Goodbye. Thank you.